we've kept it as a no ego, no politics organization. So, you know, there's no president, prime minister and all that. So,
That's true.
and youngsters are getting involved. I mean, to whichever level they can go up to, depending on their other interests.
Right.
So, wonderful. And so happy to know that, you know, both you and Vishwajit have really, you know, soldiered on.
Along with Partho, sir, he's one of the.
Partho.
Thank you, sir. Thank you, sides.
Must definitely met you when I came there.
Yes. You have met him. You have met him.
I'll just take a minute off. I'll just be back. You're starting at 9, isn't it?
Yes, sir. 9.
I'll just be back. Few minutes. Just...
Can I say just the things which I am going to say, because it is. Hello.
Yes, please.
Yeah. Very good morning, dear doctors. First, I would like to thank the GVSB group and
তোমাক হেৰিয়ে ক'লে খামছাই ক'লে
কৈছো he to practice কৰিছে এতিয়া কৈ আছে
sir কিবা নিয়মলে modify কৰিব লাগিলে কৈ দিব sir
কৈ দিও go ahead
I would like to thank GVSB group and Airway Center Pratiksha for allowing Sanofi to be associated with this in this innovative and power-packed Airway web series and workshop, which will be a series of interesting topics which will run throughout the coming week. My name is Arun, and I would like to thank you. And I work as the area manager for Sanofi India's mass therapy team. As we fight COVID-19 pandemic, we at Sanofi India are aware of the efforts you are putting in right now to ensure the well-being of your patients. We want to thank you for helping us in fighting the virus. Right now, what is very important for all of us to stay safe via social distancing. Sanofi always believes in spearheading in dissemination of scientific information and updates to help you make an informed decision in treating your patients. I would like to thank once again the faculty, especially Dr. Raman and Dr. Sivani, for honoring us by sparing their valuable time in preparing for this series. I would like to thank once again for partnering with Sanofi in imparting knowledge to the HCP, which will help in better patient care in this unprecedented period. Thank you, sir.
Yeah, Arun, remember, you have to come in every day in the beginning. Okay. Every day you have to remember to come in, log in.
Yeah. The same this thing.
Same thing. You can shorten it in the later talks because this is the first one. You need to say a little more. In the subsequent parts, you can say even less if you wish to. It's all up to you.
Yes. Different days, different faculty from outside.
Yes. The faculty will change.
So, I will thank the faculty.
Yeah. It's there in the brochure only, so there's no problem. And we will all log in a little early anyway. Since day 2, 3, 4 will be 7 to 9. So we are going to log in, say, at 6:30. And so when we log in at 6:30, you can just sort of plan it out.
Sir, I'll not show my video. Is that okay? Or shall I say?
If you're still in your sleeping, you're still in your sleeping suit, it's fine. You need to show your face.
I'm in attire now.
Only the upper part needs to be well-groomed. That's the
well-groomed
webinar.
So it was a very hard work, and Doctor this thing Vishwajit Gogoi and you had to. For
me, it was not much. For Vishwajit, he is taking care of the technological part also. That is something I don't understand so much.
And he was well prepared also. I could see the invites and all. Very good. Right. It was like a professional this thing. And it has gone to maximum. How many, Dr. Vishwajit, how many registration till now has been?
I think registration in the webinar has been 100 plus something. I think the total in the airway workshop, if we have around 200, it will be very good because it's not everybody's cup of tea. Airway is not, it's not like FES or otology, that those are different subjects. Those are subjects where you get cases all the time. Airway is not everybody's everybody's interest. Everybody can't do it. If you don't have a proper setup, you can't do it. So let's hope our target is mainly the youngsters. So young people, postgraduates, if they come in from all the specialties, be good, because we are not making a high funda sort of thing. No? It's very basic, the discussions. Vishwajit, where are you? It is 8:53. We should start exactly at 9.
So we are ready to start.
No, don't start now.
So just saying that we are ready.
The problem with the background is that there seems to be a sort of silaute on the side. Na?
Yes. And if there is movement, then it kind of just disappears.
It's a virtual background.
Mm-hmm.
Shivang, who will be talking first? Dr. Kalita.
Yes, good morning, sir. That's me, Dr. Sanchita Kalita.
So after you, Dr. Arun, then after Arun, you can announce, then I'll give the introductory thing. And then Dr. Daisy will come in with the Utpaljit's tribute. After the tribute to Utpaljit, then Dr. Raman will say a few words. And then I talk back to back the history and the airway team thing. Okay.
It is showing a live in YouTube now.
Did you open the balcony door?
Partha, Biswa got goal. Biswajit Gogoi,
Biswa, sir?
ready hobole kwa? We are about
Yes, sir. Yes, sir.
time out start korai bhal aru. Lagle we can go slowly. Let us start at 9 exactly. Aru tate gom pai noy on the website how many people have entered actually.
Yes, sir.
Partha, hello, Partha. Hello.
Oh, sir.
Hey, Amar doctor from Bangalore, not Dr. Raman. Amar,
Raman, sir.
Dr. Subramania, na?
Dr. Subramanian.
When did he come?
He came last year.
Last year, na? For your meeting.
Pediatric Pulmonology Conference.
Pediatric pulmonology.
Update. He is presently the Secretary of Indian Academy of Pediatrics. Respiratory Center.
Jaikumar sir has also joined.
Oh, wonderful.
We have called the faculty actually. If they're interested, they could join also.
Wonderful. Yeah, it's always nice. Yeah. With no live meetings going on.
Yes, yes.
And the second and most important thing is I'm meeting a lot of friends whom I never used to meet so often.
That's true. That's true.
And it's good to know their well-being. Day to day we are living these days. There seems to be no end in sight.
It's very true. Very true. This is it.
Sir, please.
8:59.
Oh, yeah. We will start at exactly 9.
Fine. Okay.
Good morning.
How is the lag now between our Zoom and
Yes, sir. Good morning.
Jaikumar sir has also joined. Yes, sir.
Morning.
Yeah, yeah. Sir, your camera is
Upside down.
upside down.
Oh my! What? How did it happen?
We are seeing 3 of you actually, and that too upside down.
Let me go for now.
What Dr. Jaikumar told me, we are all on the same side of the equator.
It's 9 now, sir.
Now we are ready, but we are just waiting for the live streaming. Once the live streaming starts, we'll start away.
Okay. in these 3-4 months, all of us has become so techno savvy. We hardly knew any Zoom, any webinars. And today, everybody knows so many things.
True. Are you also having a lot of video consultation in Guwahati?
Some people have started. I haven't, sir.
You haven't started.
I still couldn't convince myself. I'm planning to, but still, I sort of, yes, we do it, give advice on the WhatsApp, etc., but not true consulting in that sense.
But I think we all should start doing that, because
Yes.
Over the last couple of months, we've seen it increasing more and more numbers,
Yes,
and there seems to be no end in sight. Again, we are in lockdown from today for another week and 10 days. And back.
Our lockdown is continuing. It's been extended
Oh.
again. So that's what I'm thinking. I'll actually planning to do from next week.
See, many times, even the patients whom we've seen earlier, they want to just be reassured.
Yes.
And it's not the ideal best, but then, definitely it at least keeps you in touch with your patients, and
That's true.
really useful. I think that also technologically, I think will improve a little bit. Actually, what our hospital has done, I don't know whether it's a model that some of us can follow, is it comes through the hospital, and we have a doctor in the hospital
Okay.
who has access to all the medical records. So you can just sit at home. So we've got 3 windows.
Right.
So that facilitates.
That's a big help.
Hello, sir. So we are live now. I think we can start.
Yes.
Hello, everybody. I, Dr. Sanchita Kalita, on behalf of GVSB Group and Pratiksha Airway Center, would like to wish a very good morning to all the respected delegates assembled in today's session. Firstly, I would like to request Mr. Arun Singh Sobam of Sanofi to speak a few words to start the session.
Thank you, Dr. Sanchita Kalita. Very good morning to all the dear doctors who have joined. First, I would like to thank GVSB Group and Airway Center Pratiksha for allowing Sanofi to be associated in this innovative and power-packed airway webinar and workshop, which will be a series of interesting topics which will run throughout the coming week. My name is Arun, and I work as area manager for Sanofi India. As we fight the COVID-19 pandemic, we at Sanofi India are aware of the efforts you are putting in right now to ensure the well-being of your patients. We want to thank you for helping us in fighting the virus. Right now, what is very important for all of us is to stay safe via social distancing. Sanofi always believes in spearheading in dissemination of scientific information and updates to help you make an informed decision in treating your patient. I would like to thank the faculty members, especially Dr. Raman, Dr. Shivani, and Dr. Jayakumar, for honoring us by sparing their valuable time in preparing for this series. I want to thank once again for partnering with Sanofi in imparting knowledge to the healthcare professionals who will help in having the better patient care in the unprecedented period. Thank you, sir.
Thank you, Mr. Arun Singh. It is my pleasure to introduce to you Dr. Gautam Khaunsa, an otolaryngologist par excellence, the chief consultant and HOD of Nightingale and Pratiksha Hospital, and an eminent face of the northeastern region of India, to kindly brief us on this live instructional web series on pediatric airway. Over to you, sir.
Thank you, Sanchita, and thank you, Arun. Good morning to all my seniors and friends who have logged in to this pediatric airway webinar. In fact, our idea of doing a pediatric airway course or a workshop goes back a long time, and but somehow it was not materializing. And by the time things were getting together, then the pandemic broke out and everything went haywire. So we planned to come up with this pediatric airway with a lot of encouragement from many of us senior who are national faculty here. So we are a group of, sorry, you can say passionate airway workers. So our actually journey in pediatric airway has been like this. I've been the senior most was doing basically foreign body removals, aerosol tract and bronchoscopies, etc. But true airway work was not happening. We were not actually properly trained. We didn't have so much in our undergraduate periods as well, postgraduate periods also. Then came this person, Dr. Philip Monier, who started coming to Mumbai. Actually, Dr. Monier had come to India for the first time probably to Guwahati in 1999 during the AOI conference as a guest of honor. And then Dr. Monier, when he came to Prince Ali Khan Hospital and started collaborating with Dr. Sultan Pradhan, me and Dr. Kudus Ahmed, my senior, we attended the workshops and we were stimulated to try and work. But you need a group, you need a team. The team wasn't happening. Then this Pratiksha hospital opened and many new faces, new energetic people joined. Partho Pratimbara, the pediatrician, then Utpaljit Borman, in whose memory this whole webinar series has been conducted of anesthesia. And then we had Biswajit Gogoi. And these three guys actually were so enthusiastic that our pediatric airway center actually took off. And this book by Philip Monier is like a Bible for me. And for people who have read it and for people who haven't, please do try to get this book. Every word there's no word or sentence which has been extra or unnecessarily written. It's a Bible, as I say. Then we started working and we did our first workshop on airway in 2015. Dr. E.V. Raman, Dr. Vijay Sekharan, you can see him on the screen from Pediatrics, and Dr. Rakesh Garg, he has also joined in to this meeting. Thank you, Dr. Garg, for joining from Anesthesia AIMS. So they were also there as part of the faculty. This workshop was also, as I said, was done with the ENTs, the pediatrics, and the anesthesiologists. We worked as a joint, it was a joint platform. Dr. Vijay Sekharan was instrumental in actually stimulating us to go for pediatric bronchoscopy. Dr. E.B. Raman has been like a father figure. He has been instrumental in helping us start our airway center. And of course, he's always ready with some advice whenever we need or any help. And his continuous workshops and all those that he's conducting, he has tried to make a lot of change in all over India in airway work, and we have been benefited by that as well. We in fact brought out a small booklet, the handbook on that workshop, and where Dr. Raman, Dr. Garg, Dr. Vijay Sekharan, and they had also contributed. Now this airway webinar, we have said it's part 1. We hope we will be able to do a part 2 on adult airway as well, and some of the topics of pediatric airway that has not been covered in this 5-day event. And it is in memory of the person you can see on the left-hand corner who suddenly left us, Utpaljit Borman. You need a brave anesthetist in an airway team. He is the core, he is the pillar actually. But we are lucky that we have Dr. Daisy and Dr. Parikshit helping us now. They are also doing a very good job. This is a joint platform, as I said. We have the NEB-AOI, that is the Northeastern branch of Association of Otolaryngologists of India, the ISA, the Anesthetist Forum, and the IAP, along with our partners, event partners, Sanofi, as well as Olympus. So these are the national faculties, Dr. Raman, about whom I have told you, Dr. Subramania NK, who he was here last year for the pediatric pulmonology course. He's also an excellent speaker. He will be there on day 2. Dr. Jayakumar has also been a go-to person. Anytime we fall into any trouble with pediatric airway or other things, we immediately call him up and have his free advice. And Dr. Jayakumar sir, thank you for coming in today also in the morning. Dr. Sashidhar Tatavarti is also a young and very energetic guy working in airway, and Dr. Sachidhar will be joining us on the 3rd day, on Wednesday. Dr. Rakesh Garg, thank you Dr. Garg for logging in today. He's there on the last day to speak up, to give you overview about the anesthesia part. He's an excellent speaker and a dedicated airway person dedicated to airway work. And these are our local faculty. Me, Dr. Parthal Pratim Bora, our pediatrics colleague, Dr. Biswajit Gogoi, Dr. Keshav Kumar, he was in Delhi Max for a long time. He had a lot of exposure there. Dr. Deji Gogoi, our anesthetist, and Dr. Parikshit Hazarika, our visiting anesthesiologist. Dr. Biswajit Gogoi has been the most enthusiastic person in the group, I can say, in trying to organize this whole event. Over enthusiastic at certain times. And sorry, there's a disclaimer though, while I welcome you to this meeting. The disclaimer is that we do not claim to be experts. We are just a bunch of passionate airway workers, and we want to sort of spread the word. We want to bring the knowledge to everybody. We know we may be making mistakes, and for that we have the national faculty, the experts, who will be giving you the right take-home messages. So with these few words, I welcome you all and hope you have a fruitful knowledge sharing in this time. Thank you. Thank you very much.
Thank you, Councillor. May I now request Dr. Daisy Gogoi ma'am to present the tribute to late Dr. Utpaljit Burman sir, who was one of the founding pillars of Pratiksha Airway Center. Over to you, Daisy ma'am.
Good morning, everyone. We know you would be with us today if heaven wasn't too far away. Dr. Utpaljit Burman, a colleague of mine, he was a Libran by birth, but he was an anesthesiologist by choice. And as a team leader of Pratiksha Hospital in the OT staff, as a team leader in our Pratiksha anesthesia department, he was extremely passionate about his subject, and constantly we used to endeavor new techniques and new procedures of doing. So we started a journey as a private practitioner in a way back in 2008. And in last 12 years, we had grew the department with him, and we had crossed many hurdles, but we had been able to bring our anesthesia department of Pratiksha to our national level. He was committed to the hard work to improve the anesthetic practice and techniques. And every day he loved to take challenges. And sometimes I used to prevent him, like, no, don't go for it so much. But the thing is that starting from the ENT pediatric airway, which is the most challenging task I find in giving anesthesia, and to the extremes of the geriatric age group, when it is like 90, we even did that 99 or 100 years trauma cases. And we had acquainted with all kind of new cases using our ultrasound, our regional anesthesia techniques. We had tried to improvise our techniques day by day. And he was actually very particular about the quality care of the patient, the improvement of our hospital services to the patient for the improvement of the quality. And we had done, again, our hospital Pratiksha is also well known for your obstetric care. So we had done a lot of high-risk obstetric cases, and we are happy to say that we had made it really possible to give life to that high obstetric, bad obstetric history cases also. And Dr. Utpal was, he was really had an innovative mind and a thinking process. And he was very updated with all kind of scientific, and he was a techno lover. He loved all kind of gadgets, and he had in-depth knowledge of everything. followed sometimes.
Yeah.
In short, anesthesia department, we have organized many kind of webinars, not before, but this time we have organized many time of your workshops and conferences under the anesthesia department under Pratiksha banner during the past few years. And today it's really nice that the JBSB group and the Pratiksha Airway team has given such a wonderful tribute by presenting again an academic session, which was always close to his heart. And he will be never forgotten by our and I pray that may his soul rest in peace forever. And thank you all. Can you share some pictures? Pictures.
Good morning. Just want to off video and make videos. Can you, just a minute. Yeah, just I want to say a few slides of Paul Prabhan.
Biswajit.
Yes, sir. It's some coincidence, that's why.
I think we can show the slides later, where I think we can get ahead. We can ask.
Can you move to the next, Sanchita? Because it's little lagging.
It's okay.
We'll share the photographs later on. Okay.
Dr. Sanchita, please come in. While Biswajit gets the slides ready, on behalf of Sanchita and on behalf of the entire organizing team, I'd like to request Dr. E.V. Raman to say a few words before we actually get on with it. Dr. Raman, sir. Sorry. Dr. Raman has been muted. Sorry.
Is it okay now?
Yeah, I can hear you.
Okay. Yeah. Gautam, thank you very much for inviting me for this wonderful series. Thanks, Biswajit and Partho, all three of you whom I met many years back in Guwahati, and you gave me the opportunity to be part of your trip journey in the pediatric airway. I'm feeling very privileged about it. I need to thank Sanofi because it was one of the Sanofi meetings that I met Dr. Gautam Kaun many years back, and we struck up a wonderful professional and personal friendship. And Dr. Jayakumar is here. I keep repeating it every time I go. He was the first person who gave me a chance to speak on any forum of importance during the South Zone conference, which he organized. I'm still very indebted to him for that. And then, of course, the fact of the matter is that we've been running this so-called Children's Airway and Swallowing Center in Bangalore for many years. And I found I'm totally homebred. I'm a thoroughbred Indian educated, Indian trained doctor. I never had the opportunity to go and train abroad. But then this problem is the elephant in the room. We have the second most populous nation in the world, 1.3 billion people. And out of every 250 births per minute globally, India's share is around 30. That means it's one birth every 2 seconds. So finally, what we have is 41% of our population, that is about 400 million, below the age of 18 lives in India. It's the largest children's population, pediatric population in the world, larger than the population of many countries. So, and also because of the advancement made by our colleagues in pediatric intensive care, neonatal care, our OBGY and fetal medicine specialists, the IMR, the infant mortality rate has really gone down, and by about 42% in the last 11 years. That puts us in a position where we need to take care of these children who would have otherwise died, who are still living. So there's a huge area there where, as ENT specialists, we need to get trained in this and train in collaboration with the specialties Dr. Gautam had mentioned too. With that, I think we'll kick off the program. I don't want to come in the way of the program. It'll be fun participating. I'm looking forward for the next 4 or 5 days of learning, exchanging information and experience. Thank you very much for including me in this wonderful program of yours.
Thank you, sir. Thank you very much.
Welcome.
Biswajit, can you show the slides?
The slides.
The Partho's pictures?
Not sir, Paul's picture.
Oh, sorry, sir.
Yes.
Yes.
It's a very emotional moment for me actually, sir. And actually, I always organize something with Utpal. These things may happen. Maybe I may be the organizing secretary, he may be the treasurer. And I don't know. He is not an anesthesiologist for me, actually. He's more than. Can you mute everybody? And this is Utpal Burman. I know why this slide is starting.
Biswajit, use your mouse, it will move easily.
Sir, actually what happened, because I am sharing from the same laptop now, that's maybe the issue.
Then you can.
Just again, I'll try again once.
You need not put it
because from the same laptop. Sir, sorry, sir. Again, so I will share it later on. Please, we should proceed for the next things because neither it will be late, sir. So I'll share it from a different laptop. Sansita, can you go for the next program?
Our first speaker for today's session is Dr. Gautam Khaunsa, and he'll be speaking on the history and building up the Airway team. Over to you, Khaunsa.
Yeah, I hope you can see my screen.
Yes, sir.
Good morning again, everybody. See, normally when we have a workshop or a conference, we usually start off by lighting of the lamps and the Saraswati Vandana and maybe a Guru Vandana as well. So this we are not doing, we are not lighting lamps. So at least I thought even though it was not in the program, I thought we'll just briefly go through the history of how Airway had developed, because as Isaac Newton had said, if I have sinned further, it is by standing on the shoulder of giants. This is something we all need to understand. Actually, the slide has changed, right? Okay. So in around 360 BC, Hippocrates advised the introduction of a pipe into the airway of a suffocating person. He was the first person to actually realize that a suffocating person may be relieved by putting something like a stent. In 1080, Avicenna of Bukhara, Ibn Sina as is known, used a silver pipe. He used it for the same purpose. Vesalius in 1542 observed that an experimental animal whose heartbeat had stopped when the chest was opened could be revived by introducing a reed in the airway and using a bellow. So basically he was ventilating the patient. He had intubated and ventilated the patient and the animal, and the animal could live. So this was a very interesting observation by Vesalius, but he thought that the airway, the windpipe, was part of the circulatory system at that point of time. 1744 to 95, Dassault advised nasotracheal intubation for treatment of suffocation and removal of foreign bodies. Manuel Garcia, for those who are not aware, he was not a physician, he was a teacher of singing, and he observed his own larynx with dental mirrors. That was one of the landmark events in 1854. In 1862, Victor von Bruns removed a polyp from the vocal cord of his own brother using mirrors. Sorry. And see, then came the part of illumination. There are three things in airway. One is instrumentation, the other is illumination, and the third part is anesthesia. So illumination into 1805, Philip Bozzini developed the illuminator that you can see on the screen. In 1853, Desormeaux introduced the word endoscope for his instrument to examine the body cavities. And von Mikulicz actually, sorry, just a minute. Von Mikulicz and later developed the first suitable gastroscope. Kirsten started to intubate the larynx with the esophagoscope. Actually, Rosenham accidentally did it in 1894. And Kirsten, when he started doing it, he called it otoscopy. And in June 4, 1895, Gustav Kilian attends Kirsten's lecture at Heidelberg and realizes the importance of this observation. This was actually in Heidelberg in 1895, when the second conference of the South German Rhinolaryngology Convention was held. And there Gustav Kilian actually listened to Kirsten. This is Gustav Kilian actually doing a bronchoscopy, where they used to do it initially with the patient sitting. Gustav Kilian in 1897 at the Polyclinic of Freiburg University in Germany does the first bronchoscopic removal of a foreign body. And in 1898, he publishes the paper, The Bronchoscopy and its Application in Foreign Body of the Lungs. And from that point of time, Freiburg in Germany becomes a mecca for people who wants to learn bronchoscopy. And in fact, they used to do more than 10 workshops in the year. People from all over the world, including more than 200 from USA, actually attended his workshops on bronchoscopy. Let's look at the local anesthesia development. Prior to the discovery of cocaine, many other drugs like morphine, ammonia, etc. were tried, and patients had to undergo desensitization training before touching the pharynx, because patient used to come and the surgeon used to put the scope inside his mouth and desensitize. The patient would get used to having the scope inside the throat, and then the examiner had to be precise and swift in accomplishing the act. In 1848, Morton in Boston introduced chloroform, but it was found to be too dangerous for laryngoscopic procedures. In 1882, Sigmund Freud, a young scientist in the Pharmacological Institute of Vienna, experimented with a sample of cocaine he brought from Merck & Co. It was the same Sigmund Freud who became the psychologist. He tried it for de-addiction of morphine addicts with disastrous results. Sigmund Freud actually, when he brought this cocaine sample from Merck, he thought that he shall be earning a lot of money and we will be able to marry off his longtime fiancée, but it didn't happen that way. And but he also observed something. Sorry. Freud observed that the cocaine solution caused numbness. When he put it on the tongue, he found that it makes the tongue numb. He advised his colleague Kohler, an eye specialist, to try it for pain relief in conjunctivitis. And Kohler experimented and announced the new local anesthetic in 1884. Jelinek, a Viennese laryngologist, used it for airway inspection. And the whole laryngological examination changed from that point of time. In 1911, Killian designs the suspension laryngoscope, and Siffert, his co-worker, improves upon it by adding the chest piece. In 1992, Klein-Susser later perfects it in 1964. But from that point of time, with the suspension laryngoscope, gradually the patient was people started examining the patient on the lying down position. Killian was called actually the Semper Ridens, that means always smiling. He was also called Santa Claus. Killian met Chevalier Jackson during his visit to USA in 1907, and that was again a very important event because Jackson, along with Pilling, his instrument maker, brought about many improvements in instruments for bronchoscopy and esophagoscopy and was named the father of American bronchoesophagoscopy. He published the first systemic textbook on bronchoesophagoscopy, which is again considered to be a very valuable book, and dedicated it to Gustav Killian. Jackson also addressed issues of design of bronchoscopy suits, arrangement of equipment, staff, and quality management. Interestingly, Chevalier Jackson was a philanthropist, and he had designed so many instruments, but he never patented any of the instruments, saying that he wanted the instruments to be popular and more people to be helped by his the instruments that he had made. The other landmarks, if we look at it, Hasinger of Vienna introduced telescopic optics for bronchoscopy in 1940 and optical forceps in 1948. And Shigeto Ikeda of Japan introduced a glass fiber illumination for rigid bronchoscopy in 1962. He later developed the flexible fiber optic bronchoscope in 1966 and introduced a video technique in 1987. He passed away in 1989. Probably had he lived a little longer, he would have found out many more things. With this brief history, it's sort of paying a tribute to these people who actually changed the way people tackle airway problems. And this is a philosophical sort of thought, especially in these epidemic times. This is very important. And in fact, my idea of putting this into place is that people who are really into airway will realize that it's not something where you really earn money. You earn actually a lot of goodwill and blessings from the patients. And who can tell us better than Dr. Raman, who has been doing a lot of social service in this regard. So should I go along with the next talk where at the same goes, Raman sir? Hello, Dr. Raman. Sir.
Yeah, I think you can go ahead.
Yeah. He's been muted probably. So I now come to the proper program now, starting of an airway unit. Well, my job has been made easier. My talk will be a little sketchy because most of the points that are need to be expanded will be done so in the subsequent talks by my speakers that are coming up later. When we see a kid like this struggling to breathe and brought to your OPD suddenly, we really want to help this child, and to help the parents as well smile, but to know how to help this child, you need to have knowledge. What knowledge? One should know how to assess a distressed child. One should know to differentiate between starter, strider, and wheeze. We should be able to grade the strider, because if you are unable to grade the strider, you won't know which child you have to take up as an emergency and which child can wait a little longer in planning, and we have to plan our management according to our available resources. The knowledge of anatomy and physiology of pediatric airway, again, this will be covered, that is why I'm not expanding, is very important, be it for assessment, be it for surgery. We should know about the anatomy as well as the physiology in great detail. When we started doing airway work, actually most people who have to build up from their basics, most of us actually started with the 0 degree 4 mm telescope, the nasal endoscope, and a rigid laryngoscope. And then maybe a bronchoscope, even though it may not be used every day or every month even, but then this is a rigid bronchoscope is an important tool in pediatric airway because foreign body is one of the most common things. And of course, if you have a flexible scope, it's even better. Then anesthetic equipments also, there are assorted, you need assorted blades and masks, you need different sizes of endotracheal tubes, you need different airways, masks which allow the scope to go in, and of course the McGill's forceps, which is an important tool. Instruments could start from the different cold instruments, foreign body removal forceps, optical forceps if you can have it, suspension scopes, and of course different optics, different cameras. The endoscopy does not necessarily have to look like this. It does not have to look sophisticated, but the things should be in place with a proper resuscitation kit. And when we take a child to the operation theater, not only for surgery, maybe for examination. Welcome, Dr. Prahlad. In our practice, when we assess a child, this is the way we have a layout of our OT setup. We have the nurse and the assistant surgeon with a trolley behind them, so that if one of them doesn't understand which instrument to give to the surgeon, the other can help. The endoscopic monitor, if you can have a double monitor with a swivel system, then it's even better. Everybody watches the going on much better. But never ever forget to put the tracheostomy trolley inside the OR. When you have a crisis, one should not be shouting for the tracheostomy trolley. The airway team consists of a lot of people. I have put a star on the most important ones. Of course, it's not in sequence, all are important. The ENT surgeon, the anesthesiologist, and the pediatrician, along with the nurses and technicians, both in the endoscopy ward as well as in the OT, they are the core group. They are helped in turn by the neurologist, the pediatric neurologist, the pediatric cardiologist, the speech and language pathologist, and a gastroenterologist at times. The team, as you can see, usually works together. Everybody's eyes are glued to the screen. And in Corona times also, in COVID times also, we have to go around doing pediatric work, because just for aerosol spread, you cannot leave a foreign body bronchus alone. And this is again Utpaljit for you, along with Partho, who is auscultating the child, our pediatrician. The team actually needs a pediatrician. The pediatrician is pediatricians, those who are watching also, I'll have to say most pediatricians get too busy with their practice. So it's not always easy to have a pediatrician who's willing to come out of his busy clinical practice to help us in the OR. Partho is one, and we are lucky to have. Daisy, you can see, who's been around and who's always been a big help. We have been doing a lot of cases with her. When you're doing very young children, you need good backup of the PICU and the NICU. And of course, it's very important to have good recording facilities. One should record whatever you have done and go back. When you do a scopy, you go back and see what you have done, whether you have done it correctly. And that way you learn your limitations also. If you do not know your limitations, and you may act foolhardy. And always remember that the child is not a young adult. What goes for an adult may not go for the child. So with this, I end my presentation, because most of my speakers coming next will be talking about the various aspects. That is why I have kept it a bit brief. Thank you very much.
May I just say a few words, Gautam?
Yes, sir. It's your turn now.
It's an excellent presentation where Gautam has covered everything. Now, it will be very ambitious to reach where Gautam is today in the next couple of weeks or months. So one has to go through those stages of learning and then finally land up at the level that you are comfortable with. And of course, a team is very important. As you go up the ladder, you need more and more people. And sometimes we do forget one very important person, the speech and language pathologist, as you progress in your work, because ultimately 3 things are the outcomes. One is breathing well, speech, and the third one is swallowing. This is a trijunction where all these things are important. And without the speech and language pathologist, I'm sure we will not be able to give optimal results. First, it'll be the airway. Once the airway is done, the parents want good speech. And of course, much before that, for the nutrition of the child, you need to have normal swallowing. So you need to have a team. That is one part. Second part is when you're setting up these centers, your skill level is what is going to determine. But apart from the skill level, which you will, I'm sure, with your passion, you'll keep improving, is the support services in the neonatal ICU and the pediatric ICU. Whenever you do any surgery, I think surgery is easier. The postoperative care is very important. I shouldn't go too much into the depth of this because I'm sure the others are going to cover the rest of it. All I want to say is, according to me, there are 3 levels of airway: level 1, level 2, level 3. Level 1 will be diagnostics, basically, and also taking care of emergencies like pediatric tracheostomy. You should be able to do, restore the airway, etc. And the anesthetists and the neonatologists these days have so many other techniques to make your job easy. So I'm not going to talk about it. Don't want to take away the good points that the speakers are going to make. I think we can proceed with the next one if the MC allows.
Thank you, sir. Next speaker is Dr. Biswajit Gogoi, sir, who will be speaking on the instrumentation and the basic airway anatomy with radiological correlation. Sir.
Good morning, Raman sir, and good morning, everyone. Sorry, I don't know because this is my laptop.
Biswajit, for your information, Dr. Prahlad has also joined.
I know, sir. I have seen him. Basic. This was my presentation. I love this presentation. My slides are visible, sir?
Yeah, they're visible.
Okay, sir. Good morning, everyone. This is my first talk of today on basic airway anatomy. I'll try to correlate a little bit of radiology, though we have another session on airway radiology on the 4th day of this webinar series. As Council has said, children are not small adults. This is a great remarks by Peggy Orenston. And airway, the very precise, I'll not go that very basic anatomy. I'll go a little bit of clinical anatomy, which is more emphasis on endoscopic anatomy, surgical perspective, and morphometry. In Assamese, it is called Jukhma, and along with the radiological correlation. So if you go endoscopically, the airway is divided as upper airway and lower airway. And the upper airway basically nose, nasopharynx, oropharynx, hypopharynx, and larynx up to cricoid. And lower anatomy start from trachea, main carina, right bronchial and left bronchial tree. Little bit of embryology, very tough for me actually. And thanks Sansita, who is helping me to go through my first MBBS embryology. And basically it's a outpushing from the ventral and of the foregut, which is called respiratory diverticulum, which developed as the 4th week of intrauterine life. And then they developed the epithelial lining, and which is basically endodermal origin. And the cartilages are developed from the splenic mesoderm. And this is basically respiratory word, which is growth, crani, and cordially. And it gives the respiratory structure and also the swallowing, that means esophageal structure. I'll not go detail that much. And as of the first slide, this is a basic position of the laryngeal structure. It is basically at the level of C2 and C3 level, and when goal becomes low, when it becomes adults, it is C5 or C6 level, or C6 or C7 level. So that means this whole larynx is as a whole high up in case of children, and they are obligatory nasal breather. They can that means they can suck and they can breathe simultaneously. That's a very interesting phenomenon for the children. And due to the external morphology, this is the muscles involved: stapes muscles, suprahyoid muscles, and this is the intrinsic. Here, so we are showing the intrinsic muscles, And this is a more important in case of in perspective of reconstructions, and all the laryngeal drop are also the important in case of swallowing and phono perspective. And very interesting, its airway is not only the airway, it's also associated with swallowing. So I have got a few days back, there's a 30 muscles involved in as a whole swallowing process. So let's start the endoscopic anatomy. So it starts from the nose and nasopharynx. This is how we can see with 1 year style nose. It's mostly sinuses are hypoplastic. And very interesting, these soft tissues as generally does not develop in the early childhood. So we can mostly have a body. That's interesting. When you negotiate the scope in a very 1 day or 2 day baby, sometimes you not get that much of hypertrophy terminate, or that means the mucosal aspect or muscular aspect is absent. And this is the level of the nasopharynx, and this is at the level of guana. And at the level we can find all the soft tissue like suction tube opening, adenoids, and when you go below, then that comes the oropharynx or hypopharynx. Okay, this is few days. This is how we can see interior of your. It's a almost 2 months old child. Then we can appreciate the interior of the nose. This is at the level of naropharynx. Pathologically, it's important for the most commonly adenoids. And I'll go details how it should look the anatomy when you do the presentation of flexible bronchoscopy, why it is important to see look which anatomy can have a look. And this is how we can enter the oropharyngeal area, bilateral tonsil. This is a lingual tonsil. And you can appreciate the epiglottis here, lingual tonsils, and this is a glottic regions. These are importance from the endoscopic perspective, airway perspective. And this is an bioinformation, as you always know, post-cricoid region, posterior pharyngeal walls. If there's any kind of infect etiology, that may be bulge here. Then we got this is a view, endoscopic view of the children's epiglottis. It's basically tubular, and this is a glossoepiglottic fold. These are the arytenoids. You can't appreciate corticulate or cutiform cartilage in children. That's where mostly in a laser work they gets vaporized. And we got the very short AEF. So in case of type 2 laryngomalacia, this gets shortened. So that's why there's a prolapse of the epiglottis posteriorly. Then below that, it's very difficult to appreciate vocal cord with this panoramic view because of the arytenoid covers most of the almost 50%. This picture is showing how the arytenoid covered most 50% of the laryngeal inlet, if you can say. And that's why it's very difficult to appreciate the vocal folds. The interarytenoid is very narrow in case of children and subglottis. So that's why you can appreciate the focal fold it is very anteriorly, and it is hide actually by the arytenoids if you very early child. And this is a glottic and this is a subglottic area. So this is a book. I have the picture from the Monier book, and here you can appreciate the thyroid cartilage is not round. It's round. It's not V-shaped like in an adult. And the interesting is that cricoid is it's round at the lower level, but at the upper level it's like a V-shaped. That means we have a two short narrow posterior area. One is due to the larger arytenoid. If you see the posterior glottic part, because in a little bit superior level, it is because of the larger arytenoid. And if below it's the cricoid, the shape of the cricoid, it's like a V shape. So we have a more narrower space in case of children, but at the level of the trachea, this cricoid is round. That's important, not only perspective of intubation, not only perspective of endoscopy, but it's a very important in perspective of reconstruction also. So trachea is, this is a tracheal and an endoluminal view of the trachea. It's a horseshoe shaped until the age of the 6 years. The anterior posterior diameter trachea is smaller than the lateral diameter. And this we can appreciate in a radiological view. This is shape trachea. And the trachea is a higher position in case of children. That's why you have to get more tracheal ring in neck, almost 10 tracheal ring, rather than 6 or 5 tracheal ring in case of an adult. So in that way, tracheal mobilization is easier in case of a children than the adults. The posterior wall of the trachea is known as the pars trachealis. We can appreciate this is the pars trachealis, the endoluminal endoscopic view. And this is how we can appreciate radiologically the elevation, the melodic portion of the posterior wall of the trachea, and in very deep expression. These things are very important developmentally. We get when you get melodic trachea, then all this compression, this is called in other words, secondary tracheal malacia cases, we got external compression because of aberrant vessels like innominate artery, like double aortic arc here. So we can suspect when you can get this kind of pathology, like I'll go through once. This I have to mute somebody. Please kindly mute everyone. Please, sir. That you can appreciate here. This so that means this is an ultrasound picture, antenatal picture of thanks to my fetal unit department who provide me the ultrasound picture where we show let's move a little bit. That's why we can get an idea of what the anatomy this child is carrying from the antenatal period. So he has a aberrant subclavian artery. So if he has a fissure, the baby was difficult with extubation after birth, and when we did the bronchoscopy in NICU, then he has a tracheoesophageal fistula. Along with, I want to emphasize on, can you appreciate the posterior wall elevation? That means external tracheomalacia. This is a secondary tracheomalacia. If you can go as he is right, as if we can appreciate here this diagram, then there's aberrant vessels which goes posteriorly and give compression in the trachea. That's how we can get the idea where the compression is. Similarly, this is a different place area where all these vessels in the thoracic region may get compressions. So it's important in case of child with a stride or child with a respiratory distress. So this is the lower end of fistula, and it was a type D fistula. So another important in the lower part of another anatomically important in the lower part of the trachea is posterior wall of the trachea. You can appreciate the fistula tract, just the posterior midline of the posterior wall. But I want to share here another very interesting video. From the anatomical perspective from the lower part of the trachea. So that's why the anatomy of lower tracheal wall is very important. We have got tracheomalacia, we have got tracheocerebral fistula. Can you appreciate there is a accessory bronchus? So here you can appreciate this. It is just at the midline posterior wall, and it is here. It's at the side, the lateral wall of the trachea. That's how we can differentiate. This is a tracheocerebral fistula, and this is a accessory bronchus, pink bronchus, or what is the other name? I forget. Swiss bronchus Swiss. Thank you, Cecily. And in radiology, we can appreciate how this you can see the accessory bronchus. So carina in is very sharp, and that's how we go right and left way. Right bronchus is straighter. It's short, so maximum foreign. That's why maximum foreign body loss in the right bronchus. And this up to carina level distance and the luminal. Let's go a little bit of extraluminal morphology. And this figure, first diagram showing it. I am again thank Monia sir for his book. It was a Mahabharat for us. It's for airway, and I have read so many times. But every time I read, I same sentence give lots times informations. And this is how the thyroid lamina is hide behind the hyoid bones, and can appreciate it is just at the midline, and it is little bit of lower position, not at the midpoint anterior commissure attachment. And this is important in case of when you go for reconstruction. And little bit of the arterial supply. It is mainly supplied by the inferior thyroid artery, also branches from the superior thyroid artery, but it has a segmental supply. So we should, when you have to walk in a tracheoesophageal groove, so please be concerned about the segmental supply. But another interesting point is that the capillary is from interluminal. There is no capillary plexus outside. So anything happen interluminally, it may be due to the cuff pressure, it may be due to interluminal injury, and due to any endoscopic procedure, bronchoscopic procedure, any foreign body that jeopardize the vascular supply of the trachea or as a whole the airway. So this is the tracheobronchial tree. I'll not go details much of this tracheobronchial tree. I'll give more details discussion during the endoscopic procedure. And that's how this bronchial tree is divided, right? You have a three main lower bronchus, upper, middle, and lower. That's how all this they are divided. And similarly, the left side is divided as upper and lower, and the superior and lingular divisions. And we'll try to discuss our more details in. Thank you so much. This is a very brief anatomical perspective of the airway. And I have not discussed yet the parts of extensive embryology and also the morphometry. If I get time, then we'll discuss regarding more morphometry. Thank you, sir. Thank you, sir.
Yeah, excellent presentation, Vishwajit. You've covered everything as usual. You've also correlated the anatomy with the various scans you showed us so that we get a kind of a three-dimensional picture in our mind. And secondly, regarding the X-rays and imaging and all those things, as you will see while we go on through the other discussions, that these are supplementary things, but the main thing is to exactly see what exactly the picture that you get during endoscopy. But these are supplementary things which help you so that you don't have any nasty surprises when you're doing the scopy or planning your treatment. We can go ahead for the next.
Thank you, sir. I'll go to the next slide. Next stop is my instrumentation now. Sansita, you can mute everyone because most probably I can mute. Okay. So I think my slides are really visible. So this is my second talk. Good morning, everyone. And when we have started the airway things, the patients comes first, then we have no instrument, only the basic instrument. And then counselor insists us to go for safety trials, do whatever you people can do. Let's bring the team. Then we got all these team member. Then gradually the instruments has come, and this is my talk basically. So in this talk, I'll go to our instrumentation. But before going for my presentation, I will share we have a very limited instrumentation. We have started. We have a center. We are doing airway walk without laser, without carbon dioxide. Sincerely, this is my sincere sharing. And we have a no ECMO, but I can tell everyone, the particularly junior colleague, at least if you have a intention, if you have thoughts that we can save, we can. Let's the diagnostics are not that the therapeutic or surgical things. We have equipments, some basic equipments help in basic airway walk. So during instruments, I'll go. This is our endoscopic. Can call nowadays as a suit, but before this is simple endoscopy room. This is our OT, and this is how we do endoscopy in NICU and PICO. That's we have on the last day. There's a talk by Dr. Parthapati Bora how we'll do endoscopy in NICU and PICO. So this is again Dr. Paul. I can't believe he's not with us, and what's the cases is required basically in airway assessment. So I'll talk regarding the basic equipments like flexible video bronchoscope, rigid telescope, right throws, fiber optic cables, and hand instrument, and how we do archiving things. So this is the bronchoscope we have. Basically, this is a video bronchoscope, and there's a difference between fiber optic bronchoscope and video bronchoscope. And the parts of the procedure, you can see this is a proximal head of the bronchoscope. It has a angulation control lever. This is called angulation control lever here. And the bronchoscope has only two directions, either anterior posterior or retroradial. But as such, you can go for like upper GI endoscopy, you can go for all the four directions in one moment. Basically, you think that this has anterior posterior direction. Then it has a walking channel. And you can appreciate what scope we have is a 2. It has an outer diameter basically. So its outer diameter is 2.8. It has a walking channel. The big black hollow is a walking channel, and the diameter of the walking channel here is a 1.2. It's a very good therapeutic scope since it has a 1.2 walking channel. And since its outer diameter is 2.9, you can do walk neonate also. It's always good to see if you have a 2.1, but 2.1 again, there has no walking channel. So it is a suction valve. It's an insertion tube. As a whole, this tube is called insertion tube, and the distal end is called deflectable distal end. As I have, this is a part of the as a whole bronchoscope. This is a video bronchoscope. This is a scope connector. This is the universal cords, and these marks are some marks are there. So these are the measuring marks. This is the bending portions. And I want to say here, this is a very interesting scope. It's a hybrid scope. So why it is called hybrid scope? Generally, all the bronchoscope, the camera element is always camera element is always at the CCTV, this is called camera element is at the proximal end, but here it has in a distal end, but it has, because since it's a very narrow scope, it can't incorporate the camera element, so it has a proximal camera element. So basically it is a fiber scope which through the fiber. In other scope, suppose in 5.1, 5.9 scope, they carry the electronic messages. Because the camera is there, they catches the video and they send the information through the universal code to the processor. But here, here this camera in the proximal end, so it's basically a fiber scope, but it is a video bronchoscope. So during my most demonstration part, I'll say more on these regards. So when go for the what scope, we mean initially that we are confused that what scope we go for our endoscopy. So this is we always look for the specification. So what is the optical system? What is the field of view? It's 90-degree direction of view. These things are very important to know your gadgets, the depth of field, and the insertion tube. Distal end of what is the distal end diameter? It's 2.8. Sorry, it was 2.8, and working length is 600 millimeter. And what about the instrument channels? This is a very good instrument channels, 1.2 millimeter instrument channel, which is we can use for suction. We can normal suction. We can use for taking ball. We can use for any interventions like carbon dioxide, laser, electric, but here you can't do all these things with this scope because this element is, because they need a different fiber configurations here, but that fiber configuration is not here. And how much bending they can do up and down. They have I have shown bronchoscope have a 2 direction only. Either you can say anterior posterior, either I can say up and down. It is a 180-degree up and down is 180. So these things we have to look before buying your scope. It is not only the outer diameter, not only the working channel. First, it's a video bronchoscope or fiber optic scope. So what is the advantage of video and fiber optic scope? Then you can see in workshop. And this is the bending. Why bending is required? To go for the different angulation in the terminal bronchial. So this I'll skip. So I have learned these things, how we can use the other use of this bronchoscope. I have learned in last phonocon by Sandhu sir, because now the airway evaluation is not only the airway evaluation, is as a whole evaluation of the swallowing evaluation. Yeah. So here you can use the same, I'm not saying the 2.8 scope. For the younger children, I use this my 5.9 scope as a flexible upper gastroscope also. So here what we have designed, I have learned it from Sandhu sir, Kishore Sandhu from Switzerland. He used a BP cuff as an insufflator. And because esophagus is as a whole collapsible things, so you need something where you can inflate the esophagus. In that way you can inflate the esophagus, but it should be very cautious because it's not an ideal gastroscope. So there's every chances of wear and tear of your fibers, and you need a very good sedation of the sile so that your scope should not destroy. So basically we look for in gastroscopy LPR, GR, eosinophilic esophagitis, esophageal atresia, tracheoesophageal fistula, and acral. These are very important, not only the airway perspective, because this all gives airway issues. If you don't evaluate the esophagus, then you can miss. They may be the primary or associated causes, concomitant causes of airway issues. So these are rigid endoscope. There's a talk by Keshav next to me. So this is how we can use the rigid endoscope. There's a non-optical and optical. This is the ventilating bronchoscope. Where you can see with the direct eye. But nowadays we are not comfortable with this kind of scope. I don't know how Khaunsa and previous surgeon, and they have given the history. They have doing lots of foreign body bronchos removal with this optical, non-optical for safe only. And nowadays we have this most ideal. If you say what endoscope we can start the airway things, then this is a 4 mm, 18 centimeter nasal endoscope This you can start any cell, any airway, diagnostic work. I'm not calling in therapeutic work, but you can start the diagnostic work. And we can use the stores ventilating bronchoscope for cervixal, which we use for foreign body removal as a also diagnostic scopy. And it is very important, very useful in case of subglottic stenosis in a grade 3 like that, because in that you can negotiate beyond the lesions and with a seat. I'm not telling without seats, it should better always go with a seat. So this is the camera light source. It is required for the rigid bronchoscopy mainly. And this is a very essential. We have to know what's the camera you have, what is a single shift camera, what is a 3-shift camera for the better resolution of your picture, and what is the xenon light source, what is the LED light source. This is a very important for optical perspective. These are different laryngoscope should have in a airway center, and this is a Karl Storz. It is better always have it is a side port is open. It's good for on and off ventilations, and also good for the instrumentation. And this is a Benjamin Lindham laryngoscope. It gives a panoramic view. This is how we do rigid bronchoscopy evaluation in OT. And we need a few hand instruments, and this for service is very important. The Lindham self-retaining false focal cord detector. And few days back, I have learned how to. It's very difficult if you have not have the pediatric size. It's generally very difficult to negotiate, and we should put in a false focal cord level. And few days back, I have seen the webinar of English where he has put he has his own technique how to stay this Lindham detector with a rubber band with a laryngoscope. It's very I like this is a laryngeal for suction, but for neonate or pediatric age group, I like this who has a ball and tip, they have not less mucosal injury, and it has a angulation, so it's very good to some good suction at the laryngeal or hypopharyngeal or PFS regions. And we should keep all this trolley. If we do bronchoscopy or any airway assessment anywhere, it may be OT or it may be endoscopy shoot or any NICU PICU, and this most probably anesthesia colleague will going to discuss. We should keep tracheostomy trolley, all this tracheostomy laryngeal blade. I like, I have learned from Utpal how to use the straight blades, and it's a very important blade but you should have all size of the laryngeal blade. All the marks or supraglottic area is very important. And this is my last slide. If have 4 mm nasal endoscope and straight blade laryngoscope, I can do mostly 80% diagnostic work, and maybe 20. It is 50 is too high, not therapeutic, but 80% diagnostic work we can do with a 4 mm nasal endoscope. Why I'm telling 50%, I'll tell later on how can do this 4 mm scope help in a tracheal mass and all these surgical issues. And what flexible bronchoscope we like? I don't like fiber optic bronchoscope. I'll like if I have 2.9 or 3.1 outer diameter bronchoscope and with a 1.2 working channel. So thank you so much. That's all my instrumentation. Thank you, sir.
Am I audible?
Yes, sir. Yes, sir.
In the comprehensive talk, I think you showed all the instruments. The vocal fold retractor is very, very useful, and as you said,
yes, sir.
You
yes, sir.
with the band so that it,
yeah, sir. That's very. I don't know that things. I can use a rubber band. Few days with the Professor English has shown in his webinar.
So that's a very nice way of using it. And in spite of that, sometimes it can slip and things like that can happen, especially when you want to shoot some pictures and somebody else is using the rigid scope. One or two important points is for the beginners, in case you need some help. One is, of course, intermittently the mask can be used and you can have a look, and then during the apneic time. Other thing is also to use a laryngeal mask. You can use the flexible scope through the laryngeal mask. Be very careful that you don't damage your flexible scope.
Sir. Exactly.
Sometimes you'll have to go through the tube itself. Depending
I'll share, sir, that all. That's a very important thing, what you have said.
So I won't go to those areas now. And I think that was a wonderful talk. And only one thing I would say, I don't know, I'm sure you'll be mentioning it, but I'll mention it earlier also. that is the suction. When you're introducing it, make sure it is closed. Suction is off.
Sir, yes,
And
yes, sir.
very gently come out, but otherwise you'll be
Yes.
causing damage.
Same like tracheostomy suction also, sir. No, that's the same method we use for tracheostomy suction also.
So in our hurry and impulsiveness, we tend to push it in, and then you'll end up with a lot of edema in very small children. The whole larynx will be swollen by the time you are done a couple of suctions. Otherwise, it was a wonderful talk, Vishwadit. Wonderful.
Thank you, sir. Thank you.
Thank you, sir. I would like to add one thing, that if there is any question, it can be typed in the chat box, and all the questions will be entertained at the end of all the talks. And our next speaker for today's session is Dr. Parthapotim Borasa, and he'll be talking on the care and sterilization of endoscopic unit. Over to you, Partha, sir.
Sanchita, your host has disabled screen sharing.
1 second, sir. Okay. I think you can go forth with the sharing now.
Thank you, Sanchita. I think my slides are visible now.
Yes, yes, sir.
Yeah, go ahead. Good morning, everybody. Already we had very good discussions by Dr. Gautam Khan sir and Dr. Vishwadit Gogoi, and we are very delighted to have Dr. E.V. Raman sir and for giving his insight into the basics of bronchoscopy, both flexible and rigid. I welcome you all again. Since we have already discussed about the, we are going step by step actually. So Vishwa has already discussed about the instrumentation part. So we'll talk something about the care and maintenance of the groups. So it is very important that we keep. That we maintain our endoscopy instruments properly, because I think we need to mute everybody. While handling an endoscopy instrument, it is very important because you are handling with a very costly instrument, and especially for pediatric flexible bronchoscopes, which are very fragile indeed. And when we are using it and you're putting it through the nostrils, as well as when you are putting the flexible bronchoscope to the different other ways, like putting it through the ET tubes, putting it through the tracheostomy tubes, or to the LMAs, it is very important that we handle the instrument very gently, because this instrument, they contains a lot of optical fibers, and if you just do some acute angulation, and there could be breakage in the fibers. Though it is important that we handle gently, and it should be always accompanied by a person which is qualified and who is trained equally to assist in the equipment care. So there are a few smooth attachments which are there in the flexible bronchoscopes. These are the narrow working channels, the ports with obtuse angles, there are linings which are vulnerable to damage. And if there is damage, there is always a chance of development of biofilms inside the seats of the bronchoscope, which can later lead to spreading of infections. Spalding classification of flexible bronchoscope is it's called a semi-critical item. And since these are semi-critical items are those objects that come in contact with mucous membranes or skin that is not intact. And so since it's a semi-critical item, it is said that it requires a high level of disinfection. So after doing a procedure, or before doing a procedure, actually, you should always check the instrument beforehand. You should look at the suction channel, is it working or not, your suction adapter, whether your light source is working, and most important is the data entry or maintaining the logbook. Documentation is very important. Second most important thing is the delicate maneuverability. Since for a newcomer, it's very difficult to negotiate the bronchoscope through the airway, especially going through the glottic area, bypassing the vocal cords. Sometimes, many times we see that we try to intend to put pressure on the vocal on the flexible bronchoscope while negotiating to the glottis. And this is a point where most of the time the bronchoscope get the chance of damage to the bronchoscope fibers. Moreover, while handling the instrument also, we should be very gentle. we should always try to keep the bronchoscope in the center. As it said, always maintain the central path, and we should not try to hit the airways on the sides. So basically, we need two things. One is disinfection, and another one is the sterilization. Sterilization defined as a destruction of all living organisms, including spores, and is accomplished by physical or chemical means. Disinfection is defined as a process that eliminates many or all pathogenic organisms, with the exception of bacterial spores. So reprocessing of flexible bronchoscopy and accessories. Bronchoscope disinfection involves basically 4 steps. We need to inspect the scope before and after the procedure. Cleaning is mandatory after every procedure, and then we do disinfection, which could be either manual or automated, and then treatment after disinfection. So after doing every procedure, it's very important that we inspect after cleaning the scope. It's important that we inspect the scope. We should look for any damage, as well as we conduct the leak test. It is important. After doing the procedure, it is important. So it is important that we conduct a leak test. For leak test, actually, there are certain procedures, because if you damage the sheath of the bronchoscope, there is always a high chance that there could be development of biofilms inside the bronchoscopic sheath, and this even after proper disinfection, at many times we will not be able to eliminate these organisms, and there is always a chance of contamination, as well as many times cause spreading of infections to the person when we are doing the bronchoscopy. So presence of leak indicates a breach in the luminal surface. After we connect the leak adapter to the bronchoscope, as I'm showing it in the video, and then we connect it to the video connector. And then we run the video connector machine, and then we put the bronchoscope into the water for at least 30 seconds, and then we check whether is there any bubbling. If there's any bubbling, that indicates air bubble coming out in the water. It indicates a breakage in the luminal sheath of the bronchoscope. And if there's any breakage, it is it's recommended that you don't use this instrument again. You need to send it to the company back. So cleaning is manual and mechanical cleaning of endoscope. Cleaning should be performed immediately after use. It is to remove the blood clots, tissues, and secretions before they dry. Because if there's proteins that are present in the endoscopes, if you don't clean it properly, they will help in growth of microorganisms. And then many a times it's seen that they also chemically neutralize the disinfectants. So disinfection could be manual or with an automated endoscope reprocessor. Most of the time we use the 2% glutaraldehyde is used, and paracetic acid is also can be used. And manual disinfection includes soaking the bronchoscope and all internal channels for at least 20 minutes in 2% alkaline glutaraldehyde solution at 20 degrees Celsius. And after the glutaraldehyde soak, the channel should be rinsed with sterile water or 70% alcohol. But we should always keep in mind it should not be tap water. And an automated endoscope reprocessing machines can also be used for disinfection. Sterilization, of course, can be done with a ETO gas sterilization, where you can use ethylene gas, and sometimes you can use the steam sterilization also, that is like autoclave. Second most important thing is the storing the instruments after proper cleaning and disinfection. It should be in a proper cabinet where you should be hanging it upright, especially with the C type of holders, and suction valves and caps should not be reassembled until the time of the next bronchoscopy. And we should always maintain the temperature as well as the humidity of the cabinet where we are still going to store the bronchoscopes. Another most important thing which we should always keep in mind when we're using an endoscope, especially the power supply of the endoscopic suit should be always maintained. You should have a proper UPS and good earthing so that you don't get, it doesn't damage your instrument. So what are factors which leads to outbreaks of bronchoscopic transmission of infections? The factors like failure to do a leak test, If there's improper manual cleaning prior to disinfection, this leads to inability to neglect to clean the suction channels. If you have a contaminated water supply, contaminated brushes, and contaminated biopsy ports and suction valves. Failure to disinfect the bronchoscope, contaminated or expired disinfectant agents, dilution of disinfectant agents to ineffective levels, insufficient disinfection time, inadequate training of personnel, and inadequate activities. Ineffectiveness of automated endoscopy processors are also been, there are a lot of studies on it, and it says the improper use of automated washers, biofilms developed inside the automated washer machines, and there's mechanical malfunction of the automatic washer, and AR incompatible bronchoscopes. So this is a small study which was done in UK, and where they have taken the interviewed the nurses who were working in the endoscopy suite, as because we don't have a proper or laid down protocol for endoscopic disinfection till now. Most of the disinfectant units or the disinfection protocols are used by the protocols which are provided by the companies, and many a times it is seen that there is lack of administrative support, there's insufficient number of scopes, and the absence of clear-cut standards for infection control procedures, lack of involvement of infection control staff, and pressure to shorten the downtime of endoscope between patients. And there's complexity of the equipment which make cleaning and disinfection difficult. So it is very important that we follow the every process, every step in cleaning the instruments properly, so that we don't end up giving infection to the patients. And especially in a pediatric age group, we should follow the protocols strictly, and the protocols which are laid down by the infection control department of the hospital or the unit. Thank you.
Again, that was a wonderful talk on taking care. Most important thing is the easiest thing is to buy the flexible scope, but what is important is to take care of it, because these are all very expensive instruments, and doctors very nicely outlined the care of the instrumentation, and all these things are to be taken as words of wisdom and follow it like a true soldier.
Thank you, sir. Our next speaker are Dr. Daisy Gogoi and Dr. Parikshit Hazarika, sir, and they are going to talk on anesthesia armamentarium in pediatric airway. Daisy, ma'am. Daisy, ma'am, unmute yourself. Yes, it's coming.
Video
You can see your slide, Daisy.
Sanjita, you unmute.
Sanchita, it's coming. Yeah, good
Yes,
morning, everyone. Today, my topic is anesthesia armamentarium for pediatric airway. So next slide from John. It was Joanna and Miss. The airway devices was first used since 1940, and before 1940, there was much less pediatric intubation, or your general anesthesia was much less given because of the need. The pediatric airway, the equipments was not that developed, and after that there has been revolution changes, and since 1940 the curve is going up and the various new airway devices are coming. Now we feel much safe and protected to do a pediatric airway case also. And the airway intubation was used to protect and control the airway in children's during anesthesia, in emergency department, in NICU or PICU. An intubation can be performed either as a direct with laryngoscope or indirect visualization of vocal cord by video laryngoscope. The airway, supraglottic airway devices are also used. Now the pediatric airway, can we say that it's children's are the miniature adult? As we all know, no, it is not. Due to various anatomical, physiological differences, the pediatric airway is entirely different from that of an adult. In a pediatric, there is a large occiput, a narrow nares, a large tongue, high up larynx, narrow subglottic, floppy epiglottis, and a thin or hollow underdeveloped mandible and a very large occiput. So you will be knowing here, like if its anatomical differences are there in between the adult and the pediatric, like funnel shape with cricoid. Now the thing is that when we take up a pediatric case, we have to be very certain that whether all the equipments, our OT is ready with not to take up a pediatric case. So beforehand, we have to keep the things ready in our hand. Like the various armamentariums we have to be ready are the equipments, the drugs, the whole of the OT scenario you have to change as soon as we know that a pediatric case is coming. So the suction catheters, various suction catheters we have to keep ready, from a 5 to the 16 French catheters, or the suction catheters, and the oxygen, how we will deliver the oxygen, whether the nasal cannula is there, nasal oxygen flow, mask, book bag, the appropriate size bag is not there or not. Then we have to think of the airway, like whether the protected and appropriate size endotracheal tube is there or not, whether the Goodell's airway, the nasal pharyngeal airways are present or not, the stillets, the laryngoscopes. Then we have to be well versed with the pharmacological agents which we are using for pediatric cases. We have to make our monitoring equipments ready, like with the pulse oximeter, capnography, then our statos, our non-invasive blood pressure monitors, then IVSS is a must before giving anesthesia, and even the interosseous needle should be kept ready in the setup where we used to do the pediatric cases. So the devices are such that to allow the rapid or accurate fluid or the drug delivery is also very essential. The equipments for measuring the amount of fluid we are giving, the syringe pumps, we have to be kept ready with that. The patient warming devices, because if the patient leads into their hypothermia, then it may lead to your bradycardia. And so the patient warming blankets and proper OT temperature should be maintained. The TIVA pumps can be used. The ultrasound devices are used for the central cannulations, the equipments for measuring the weight of the baby, defibrillation with appropriate size pads in case of any emergency. So when we take up a case of your pediatrics, we have to be well versed with the recent your guidelines, difficult airway guidelines. So this is 2016, the All India Difficult Airway Association guidelines has been formulated for the unanticipated difficult tracheal intubation in pediatric age group. And this has been formulated by Dr. Rakesh Garg also. We are happy that he will be there in the next few days. He will be talking on airway again. So the thing is that we have to be ready, like what are the things for laryngoscopy and tracheal intubation are the things we're keeping ready. If that fails, what next supraglottic devices we are using or not. Then if it fails, then what next? If we can't intubate, can't ventilate, then what next? So every day we have to revise while taking a case. So you have to have a plan A, B, C, and D. If it is A, initial resistance strategy should be there. It should be stuck in the OT wall, I feel. Like in B, then your intubation, secondary intubation strategies. If you don't have that you can put a supraglottic airways, and if not, again you have to wake up the patient, maintain with a simple mask, and postpone the case if it is not a emergency surgery, and if it is an emergency, again how we will proceed to the surgery. If nothing, you can't intubate, can't ventilate, you are safe in doing an ENT case because the surgeon used to be there to immediately surgical assist. But if not, then what next? You do needle cricothyrotomy or front neck assist. So in every cases, again, the Cormack-Clahen's Mallampati score, you have to be well versed. And the various things like the simple suction, the proper size, appropriate suction catheter is very important, because sometimes what happens when you put it a tube, you don't have, you are about to put the tube, then suction secretions are there. You're trying to suction, the appropriate size suction tube is not going there. So that might all result in hypoxia, decrease of heart rate, bronchospasm, laryngospasm, and atelectasis of the lung. So the thing is that when we see like the positioning of the baby, when we take up a case, first we have to position the baby. Like the baby should be in the neutral position. The head should be in a neutral position. If it is a very infant size, then we put the support below the soldier. And if it is a small child, you have to modify like that. If it is older children or adolescents, then it goes at below the occiput. So the this soldier role should be placed so as that the neck is wide open, the neck is extended, and the baby is in a sniffing position. So the various maneuvers we can do, like the external laryngeal manipulation. So we anesthetists are also very versed with using our little finger to hold the larynx, to manipulate the larynx of the baby, and with the ring finger of our hand holding our laryngoscope. Then techniques of intubation, like intubation endotracheal tube. We have to, our aim is to put through the cricoid cartilage up to the mid-trachea. Then during this procedure, sometimes apnea occurs, so nasal apneic oxygenation during intubation is also a good technique. The proper size selection of the Goodell's airway, which is very simple, but it is very essential to place the, we have to check it whether by the side of the face of the baby, where the flange from the corner of the mouth to the tip of reach the angle of the jaw. If it is too small, again, it will lead to your will not adequately displace the tongue, and if it is too large, and again obstruct the larynx and will not fit. So again, nasopharyngeal airway should also be there in the table trolley, that like the proper size starts from 12 French to 36 French size. So the shortened endotracheal tube can be also used some infants, but we have to avoid the placement in those cases where there is hypertrophic adenoids bleeding or trauma is there. First, the face mask is foremost important, a proper size of the face mask, and we have to take a clear plastic face mask, because that makes it easier to look after if there is any cyanosis, or if there is secretions of blood coming out from the patient's mouth, then we can immediately take action. And the proper size, like this, we have seen that it is covering the mouth, face, not the eyes, where the proper fitting is there. And again, after that, here in this picture, again, you can see the manipulation of the larynx from external. The bagging units are important, appropriate size bagging. Like if you're taking an infant, you have to be ready with 500 ml, and child of 1000, adolescents of 2000 ml. So what are the goals of laryngoscopy? The goals of laryngoscopy are that we have to see the vocal cord nicely. So for that, what are the laryngoscope blade we use? Now there are various things, like in laryngoscopy, whichever is comfortable. I myself find the Macintosh more comfortable, but if it is a very pediatric age group, yes, the straight blade, they say, is more comfortable, placing it under the epiglottis and lift it anterior to expose the cord, as the vocal cord is more anterior, and the curved blades are placed into vallicula to lift up the cord. So the various sizes blades in infants is like Miller 1 or Mac-of 001. In 2 years, it is size Miller 2, Mac 2, up to 12 years. Now comes the tube size. So I feel that when we are doing a pediatric case, we should put a pasted down what is the age of the, according to the age and the size of the endotracheal tube, we have to paste it, because at the time of emergency we can't calculate using these all formulas, but still in books there is formulas for uncuffed tube and cuffed tubes. And the length of the fixation of the endotracheal tube is very important. Like it should be the triple of the size. Suppose if the endotracheal tube is 3 size, so we should fix it at the 9 centimeter. So the various endotracheal tubes which we commonly use are the PVC tubes, this cuffed or uncuffed. The microcuff endotracheal tube are also very useful. Like if we use the microcuff endotracheal tubes, then they had said that the post intubation the stridor rate as compared to the uncuffed tube, it is similar. So they had said that even if you're giving a tube with cuff, the post extubation, the patient doesn't have that much of problem. So your armored endotracheal tube are also very good, because we are using armored endotracheal tube also in some ENT cases, because that prevents your kinking, and you can be quite comfortable. But the thing is that when we are first you're cuffed, whether the endotracheal tubes, first we thought that 2.5 is the last endotracheal tube we have, but we had done a case of your complete laryngeal your web case, where there was class 4. Then we came to know that actually the size 2 endotracheal tube is available. So I urge that you have to have a size 2 endotracheal tube 2 also, because that is also necessary in some very emergency cases. So in difficult airway equipments, we think that what you should have in your setup, like whether you have a laryngeal mask airway, whether you have eye gels, whether you have a rigid or a flexible bronchoscope, bullets, fiber optic intubation, surgical airway, combi tube. These are the things which you have, but it's not that everything you should have in your OT, and it's not possible. So you have to pick up 1 or 2 for your practice. You have to be well versed with that, and you have to carry on. So the various supraglottic devices which we use are the like LMAs. The laryngeal mask airway, previously it was a little bit of cumbersome. Now what happened, the AMBU has come out with the Aura Gain and Aura. These are very convenient and very good in fixation. So supraglottic airway devices, again now your iGel has also come. So the iGel in pediatrics is also available. That is also very good fitting. So lightweight airway, we are not using that. Now come the video laryngoscope. Now in this COVID pandemic period, they had given much stress to the video laryngoscope because you are not in a close proximity to the patient's face, and you can far intubate it. But the thing is that even if you have a video laryngoscope, you have to practice it, and at a time of emergency, you can use it. Now, in this period, we have to put the child under a plastic drape, use the video laryngoscope. And so there are a lot of things. So if you are not well versed, again, it will lead to more of difficult intubation scenario, causing your more a prolongation of intubation and problem. So if you are if having problem, then if you can't intubate, can't ventilate, you have to be ready with the next step. That what next? If a surgeon is there, then you are fine. If not, then what? If a needle cricothyroidotomy, you have to be well versed. Now you have seen that transtracheal jet ventilation is not available in all setup, but if you have, it's good. But simple connections, like if you have a Dr. Parikit will show you how we'll assemble this one. One needle should be placed, again a syringe, and with that connected to the endotracheal tube, and a simple ambu bag. This will save your life in case of emergency. But the ventilating bronchoscopes are in airway, like Dr. Biswajit has also told that how we had done a lot of airway cases with foreign body bronchus. Then we could put the your ventilating IRS circuit there, and they continue with doing the thing, and from the scope we can ventilate the patient also, at least give the oxygen and the inhalation agents. So now comes the pharmacology. I won't go into details, but the thing is that in our anesthesia armamentarium, we have to keep ready with all the pre-anesthetic drugs we give to sedation in the PAC. After doing the PAC, in the preparation room, we have to give analgesics, some anticholinergic, histamine blockers. The opioids, ramifentanil is not available in India. Okay, fentanyl we can use. For induction phases, inhalation agents like Civo, Isodes, Halothane, everything can be used, but in our setup we use sevoflurane. And IV induction, propofol or ketamine can be used. For maintenance phase, for inhalation, nitrous oxide. Then muscle relaxant, again rocuronium. For fast intubation like succinylcholine. The advantage of rocuronium is that it can be reversed the sugammadex. Again, sugammadex is not available in all centers of India because of its high price rate, and atracurium can also be used. Again, the reversal phase, we can use neostigmine, atropine, glyco. So at the end of the day, when we do the case, you can say in this picture, like last 2 days back we have done, you have seen the monitor, it is like 100% oxygen of saturation of the baby. And this case was done 3 hours of laparotomy. After that, the baby is maintaining well. And we had given this hot air hose pipe. As you can see, like this hot air has kept the baby much comfortable during the OT, and the proper size fitting of the mask. And you can see 100% oxygen, tachycardia is not there. And you can see babies ventilating spontaneously. So, and this is warm blanket, and this is for there we are maintaining the temperature. So this simple setup can lead to your happy ending of everything. So the rule is that we have to use our common sense, and we should not continue doing the same thing again and again and expect a different results all the time. The first intubation is the best intubation. The easier come first, and in difficult intubation, and each difficult intubation is different, and we have to prepare for that. Thank you all for your hearing.
Thank you. That was again a very comprehensive practical tips on anesthesia, because unless the surgeon and the anesthetist are on the same wavelength, none of these things will really work. I congratulate you on your wonderful presentation.
Thank you, sir. Now, Dr. Parikshit Hajarika, he's a senior anesthetist. So we do a lot of complicated case together. And last week only we had in a laryngeal cleft also, sir. So it took like a long time, like 4 hours, 5 hours we took. So baby well maintained, and he will be showing us the various things, how we keep the trolley ready, and some of the practical tips. Thank you, sir.
Welcome.
Yes.
Parikshit, we can see you. Your voice is not on. Biswajit, kindly keep the camera steady, whoever is holding it.
Hello.
Yes, we can hear you.
Okay, sir. Very good morning to all of you, my respected seniors and dear friends. Let me recommend it. A very good morning. Let me start with the saying that literature says that difficult airway in case of a child is comparatively very less than in case of adults. But for me, I must confess that it's always an intimidating task to go for administering anesthesia and intubating pediatric patient. So let me begin by what we have done is Daisy have already given you a very beautiful presentation of all the equipments and drugs that we are using in case of a pediatric patient. So what I'm going to do is I'm going to demonstrate and show you the few equipments that we use in case of a child. But as it is a lockdown here in Guwahati, I'm sorry, I must apologize that we could not afford to procure a mannequin to show you or demonstrate even in details. So bear with me for that. So let me begin with the instrumentation. Let me show you the instruments. Let me divide the instruments into, say, first airway and oxygenation, Secondly, airway adjuncts. Thirdly, the laryngoscopes, different types of laryngoscopes that we use. And fourth, the endotracheal tubes that we are using nowadays. And lastly, of course, few surgical equipments that we use in case of a front of neck access. So, first is, as we know, first thing that we need is a source of oxygen. That is always a requirement in case of a pediatric case. But then, since this is not an OT now, we are not in an OT setup. But then we usually have anesthetic machine for our oxygen and anesthetic drug deliveries. And secondly, we must have a suction machine that has to be kept in preparation. So an oxygen source and a suction machine is a must. Second is, as all anesthetic societies have all recommended, we should always have a self-inflating bag or an ambu bag, as it is popularly known. And in case of an OT, we have what you call an Jackson-Rees modification of ISTPs or a pediatric circle absorber system. The next is an adequate adequate size mask that has to be taken. So it, as Daisy have already shown in the presentation, it should fit the mask properly so that there is no leakage in case of a child. It should not be too big or should not be too large, so that there is no leakage of any kind. So we have different types of masks here. So all different types of masks should be already readily available. So if one type of mask does not fit, we can immediately replace it with another one. So this is a special type of mask I want to show you. It is a mask with a port here, as you can see. So this is a very useful mask in case of if you're doing an endoscopy in case of a child. So you give oxygen through. You can give oxygen through this port, and through this port, this is self-sealing. You can put in a endoscope. So at the same time, you are also giving inhalation anesthetic to the child, and the and it's very helpful. Next, we come to airway adjuncts. Airway adjuncts are what you call, these are oropharyngeal airways. It comes in different sizes. How you basically measure oropharyngeal airways. Size of the oropharyngeal airway, it always
Dr. Hazarika, you are a little faint. Can it be a little louder?
Okay, sir. It's basically due to, because yes. Can you hear me now, sir?
Yeah, we can hear it.
Okay, sir. So the way in which so how do we pick up an appropriate size of oropharyngeal airway is by measuring the oropharyngeal airway from the angle of the mouth to the tragus or to the angle of the mandible. So this way we pick up the adequate size oropharyngeal airway so that it adequately fits the child. So if it is too big, as already Daisy has shown, it will go too further inside and will obstruct by pushing the epiglottis into the trachea. So if it is too small, then it will push the tongue backwards and cause obstruction. So appropriate size of oropharyngeal airway is a must. So we don't have a nasopharyngeal airway with us, but then in case you need a nasopharyngeal airway, Dr. Daisy have already mentioned that we can use a cut endotracheal tube also. Similarly, if you give a nasopharyngeal airway, we measure by putting the airway from the external layers, to the angle of the mandible or to the tragus. This way, we can pick up a fairly adequate size of nasopharyngeal airway. Another salvage airway system is the laryngeal mask airway or the supraglottic airways. We have a normal supraglottic airway here, and ambu oragan. The advantage of an ambu oragan it has a prefixed shape and is easier to insert, and definitely helps us in the ease of insertion. Now, one thing I want to mention is there are different formulas in pediatric age groups, because because we are dealing with a range of ages and range of weights, so it is very difficult to memorize as such. So I personally don't try to memorize. Before any surgery, any kind of patient of any weight, any age, so you have to basically go to the book, write all the formulas that is for that particular patient, and put it down on paper and keep it with you. So in case of an emergency, at least you can go to the paper and you can directly pick up whatever dose or size or length of tube or any other equipment that is necessary to do. So that is what we do usually. Next, we come to laryngoscopes. Different kind of blades that we're using in case of pediatric patients are usually a curved Macintosh or a straight mirror. The preference of using either of these is upon the anesthetist, because he or she will be more familiar with working with one of these blades. But I know, because I personally prefer a curved blade, because this is something we have been used to, as we have been using it in case of adults also. So, but then in case it is difficult with a curved blade, we can always go back to a straight blade. Now, what I want to show is so what do we do actually, since it has already been shown in the previous slides. In case of a pediatric patient, so as we know, the epiglottis is large and floppy in kind of a sigma shape. So usually in case of an adult, what we do is we put the curved blade in the vallecula, that is between the base of the tongue and the pharyngeal surface of the epiglottis. So this way we lift the tongue and indirectly the epiglottis gets lifted. And that way, the vocal cords can be visualized. But then it is not in every case, because as epiglottis are large and floppy, it may not be possible in all cases. So the Miller blade helps us in lifting the epiglottis. So what we do is we put the Miller's blade on the laryngeal surface of the epiglottis and lift the epiglottis as a whole. This way, we can visualize the glottis and the vocal cords better. But then, as I have said, it is up to the anesthesiologist because they know better. So newer techniques of laryngoscopes are what you call the video laryngoscopes. We don't have one with us today, but then this is something we have been using in older patients. A size 2 blade here. So it is all about using this and getting familiarized with this, because not all of us will be familiar with this, because and literature is basically little what you call literature is a little in mood in whether to use or not to use, because some say that using a video laryngoscope may increase the intubation time and cause apneic spells, and some people say that there's the time of intubation in both video laryngoscope and in case of a normal Macintosh or Miller blade is almost similar. But then the advantage of using a video laryngoscope is you're getting a larger magnified view. So in many cases, it is with a bigger screen, you get a magnified view, and it is always large. Nice to see a big larynx to put a tube in. So it is up to experience and the type of laryngoscope blade that you video laryngoscope that you're using. Coming to different types of endotracheal tubes that we have been using nowadays. Conventionally, it has been said that in case of a child, always use an uncuffed tube. This tube has no cuff. So the idea behind it is that the teaching is the narrowest point of a child's airway is the cricoid, or nowadays it is said it's the subglottic. And another thing is, when you are using a cuff tube, if the cuff is pressure is too high, it may cause injury to the mucosa, tracheal mucosa, and may later cause edema and partial obstruction of the airway. So, but then nowadays, in order to decrease the re-intubation number of re-intubations, sometimes the tube is too small, so then you have to take the tube out and put another, and to decrease too much leak or to prevent aspiration, we are going for the cuff tubes. So it has been seen that, as Dr. Daisy have already mentioned, that it has been seen the post-operative incidence of sore throat, even if you're using a cuff tube, or irrespective of you're using a cuff tube or an uncuffed tube, is the same. So it actually doesn't matter if you're using a cuff tube or an uncuffed tube, but unless you are giving a what you call right amount of intracuff pressure. So the next is what we got. Newer technology has come up It's called a micro cuff. This is a new. There's a company called Kimberly-Clark. So what they have done is they've used a micro cuff with a softer walls, which inflated actually does not cause any wrinkles in it. So it is uniformly cuffed up. Inflated up cuff. So and also the intracuff pressure is very low. Secondly, the cuff actually is the micro cuff tubes. It doesn't have a Murphy's eye, so the cuff is more distal. So it's more distal. So this actually how it helps is, so basically it will not lead to over insertion or one lung or bronchial ventilation. So that is the difference of a micro cuff. Distal cuff, no Murphy's tube, softer walls, and lesser intracuff pressure. So this fulfills all our criteria, and so that we can use it in case of a child also. So I'm sorry, I don't have a micro cuff with me. This is just a conventional cuff tube that we are using in some of the cases. This one thing I want to mention is keeping a feeding tube with me. I keep a feeding tube with me is because during difficult intubation at times, what I do is I put one of these tubes through the nose. I put it through the nose and keep it in the nasopharynx. Connect this to the source of oxygen, to the oxygen source, and put it in the nasopharynx. So at the same time, even I am taking a little bit longer in intubating, so there is at least some amount of oxygen that is getting inside the lung of the patient. So this has shown to be little quite helpful for me. So this is what I wanted to share. And this is lastly, I just want to tell you is the front of neck access in case of an emergency. One thing what I want to mention is I find it very comfortable doing cases with an ENT surgeon because they are, as you know, quite familiar with the airways and always eager to help the anesthetist. So this is but then in case of a front of neck access, this is something we are using as a crude method of cricothyroidotomy. So we use a cannula, 20 gauge cannula or 22 gauge cannula, whichever you want to use, 20 gauge or 22 gauge, whatever you want to use, and put this, puncture this in the cricothyroid membrane, take this out. This is a 2 cc syringe. Take out the piston, put this in. Take a intrathecal cuff connector. Use an ambu bag or whatever oxygen delivery system you have. Now you have at least some access to the trachea. This way you can at least oxygenate the patient for some time. This is a crude cricothyrotomy set for a front of neck access. Other than this, I'm not well versed in case of tracheostomy, but then still we have a tracheostomy tube with us. The pipeline. So it is the ENT surgeon who are basically more inexperienced to speak about this, but then we already also have this with us. So that concludes most of our demonstration today. But then what I want to tell you is in case of a child, we have other pharmacological drugs such as propofol, ketamine, fentanyl, and relaxants like succinylcholine or etraquarium. Then we what we call monitor with temperature, oxygen, blood pressure is always needed. Thank you so much.
Yeah. Is Dr. Garg in the audience?
Yes, sir. He's there, sir.
Yes, sir. I'm here.
Okay. Kindly, Doctor, this is your area. Kindly give your comments.
Sir.
Dr. Garg.
Okay.
Thank you for the nice talk. We'll just
You,
get
sir.
some comments from Dr. Garg, who will be a better person to.
Okay.
Dr. Garg has just left. He was there.
Oh, I see. I checked up with Prahlad. He's also away. He said he'll join and inform us as and when he comes.
All right.
Right. So you can go ahead with the program. Unless somebody else wants to make a comment. I mean,
where is that white fence?
Thank you, sir. Let me remind again that all the questions will be taken up at the end of all these talks, and we are keeping room for keeping time, important amount of time for discussion. We have a lot of eminent people amongst us. The next talk for today is pre-bronchoscopy clinical assessment by Dr. Partho Protim Bora, sir. Partho, sir, over to you.
Just a minute. It's visible?
Yes, sir.
Good morning, everybody again. I think after the discussion about the anesthesia and the anesthetic equipments, we are going for a pre-bronchoscopy clinical assessment in a child. It is very important that to assess a child before taking up the baby or the child for bronchoscopy. We know that the respiratory disorders or the respiratory problems amounts to a lot of mortality as well as morbidity among the infants, as well as these respiratory problems are seen more commonly in neonates also, who needs a good bronchoscopic examination of the airway so that we can identify the problems early and we can diagnose and we can provide them with adequate treatment as early as possible so as to bring down the distress and bring down the morbidity in this age group of children. Airway, as we have discussed, as discussed by Dr. Biswa in the morning, it's a very dynamic airway in children, and with age, the dynamicity changes, the airway structure, the airway, the dynamicity, as well as the different structures in the airway also changes with age. So we should have a very good knowledge as well as insight into the pediatric airway. Before doing a bronchoscopy, we should always ask this question and say, will this procedure actually alter my medical management? And if the answer is no, it is wiser to postpone the procedure. It's just because we have a bronchoscope in your hand, we should not just go ahead and just put it into the airway of every child that we have in the ICU, in the NICU, as well as in the PICU, or anybody who comes up with a respiratory problem. So basically, who needs a bronchoscopy? So whenever there's a necessary information required, is based on a flexible bronchoscopy. We should always have two questions in mind. Why am I doing this basically? And does this going to help me? And whether the risks that are involved in doing the procedure is justified. So for bronchoscopy, basically, we have got basically two indications. One is the diagnostic and the therapeutic bronchoscopy. And for diagnostic bronchoscopy, we basically look into the airway and find out the obstructive problem or the cause of the respiratory distress. Many times you can take samples. It could be either lavage or it can be a brushing. If you're thinking about a child with ciliary dyskinesias, or at times you can do an endobronchial biopsy in case of children with tuberculosis. So a few things that we should always keep in mind is the most important thing is the clinical presentation of the child. The first step of evaluation is to differentiate whether the present problem is simple or one or manifestation of serious underlying lung problem. We should always take a history of prolonged fever, persistent tachypnea, sense deformities, clubbing, and this always indicates a chronic lung problem. There are different types of cough which may be seen along with respiratory distress, a history of noisy breathing, and the most important is the persistent unexplained wheeze. Many times, especially in infants, we see a child who comes with wheeze, and they're often put onto either bronchodilators or into some controller therapies. But even after giving therapies, the wheeze doesn't disappear, and there is persistence of the wheeze. This always indicates that the child has an obstructive phenomena which is going around in the airways and which needs to be looked into. So detailed history regarding the cough, but what kind of a cough it is. Basically, it's a wet cough, it's a dry cough, it's a persistent cough, especially in children with a prolonged wet cough. We should always think about a protected bronchial bronchitis, where we need to put a scope and we need to take a lavage to see the organism inside, which will, of course, help us in identifying the proper antibiotic. As well as if you see the airways, there are this redness of the airways, basically trachea and the bronchus will indicate there's a persistent infection which is going inside. Of course, we can take a history of the sputum, any history of hemoptysis, or the different qualities of the sputum. The most important thing, especially when you're looking into an infant, is the feeding difficulties. Most of the children, mothers will often come to our OPD with a history of choking, cyanotic spells, or baby not being able to suck properly on the breast, or when they're putting the breast, you might hear some abnormal sounds coming out from the throat. This thing should always indicate that there's a underlying pathology which could result, which could be the cause of feeding difficulty. And of course, any child who comes to our OPD or to our emergency with an apparent life-threatening episode, where all other causes have been we've seen gone through the history and we have examined him, and if we couldn't find out any problem, we should always do a bronchoscopy to see is there any airway problem, especially clefts, laryngeal clefts. So other relevant history which is very important while assessing a child is the intubation history. Many a times in pediatrics, after prolonged intubation, especially in a PICU, we might get a subglottic stenosis, in which cases we might get a children will come up with stridor in the later part, as well as they can have extubation problem also. History of prior surgeries in the airways as well as in the thoracic areas and usually in the head and neck area. Other neurological conditions like if the child has got history of birth asphyxias, history of hypotonia, and other neurological abnormalities. We should always look into syndromes, and most important thing is taking a good history of allergy. So whenever we take a airway history, we have this mnemonic called SPECS, where we look into the severity of the problem, whether the airway distress is mild, it's moderate, or severe, and with what symptoms the child, grade of respiratory distress the child presents to you. Second important thing is the progression of the disease. Is it the child has been stable along with it, or is there any improvement, or there's a gradual increase in the noisy breathing or in the respiratory distress? As we have already discussed, it's important to discuss about the eating difficulties, especially air hunger during feeding, choking, history of aspirations. The child might come with recurrent pneumonia. And of course, the most important thing is always, as a pediatrician, we always emphasize on taking the weight, the length, and then plotting into the and MORPHOMETRIC chart. And if the child is less than the 5th percentile, of course, we know that the child is failing to thrive. And if we couldn't find out any other reason, we should always think about any feeding difficulties or swallowing difficulty that has led to failure to thrive. Of course, cyanosis in children would be associated with either respiratory distress or with feeding difficulties, which can come to our OPD as apparent life-threatening events. Sleeping difficulties, again, a very important history. We should always take history about sleep apnea, especially obstructive sleep apnea. When you're looking at the child, around, even we have got children were presented to us at around 2 months of age. Mothers complain of sleep apneas, and this the abnormal sounds like snoring, mouth breathing, drooling, excessive drooling of saliva, especially during sleep, and child tends to sleep on his tummy. These are signs which indicates that the child has, and especially if the child tries to extend his neck while sleeping. This indicates that there's an obstructive lesion in the airway, and which could be cause of the sleeping difficulty. And of course, if you look at the different retractions which can occur, either it could be suprasternal retraction or chest retraction during sleep. We should always take the help of investigations, mostly the airway films. Chest X-rays are often gives an information about the location of the disease, and especially when you are doing a scopy, if you have a CT scan, then we can exactly pinpoint where we want to go actually, which part of the lobe or which part of the lung we are more interested in, and which will yield us more information. So we should have a proper investigation like chest X-ray and CT scans in hand before going for a bronchoscopy. So there are different airway sounds that the child can produce. Mostly the different parts of the airway produces different kind of sound. The nose and the nasopharynx will give us leads to stators, snorting, or the grunting. And these are basically low pitch sounds which are result of the vibrating sounds from which occurs from the movement of the muscles in the nasopharynx. This is very usually stators are very common in children who are less than 6 months of age, and we often hear these sounds which may not be pathologic in infants. Other sounds like oropharynx, and from the hypopharynx we have the snoring sounds, and then the most important sound that we often encounter that comes out from the larynx or the trachea is the stridor, and from the lung we have the wheezing sound that we can hear. These are a few videos where we can hear different sounds. This is a typical stridor.
Hello?
I think from the videos you can quite well see the even for this first baby, although the stridor is less, there's the breathing sound, the noisy breathing is less, but the distress is even more, and the child is actually oxygen dependent. And whereas in this child with the higher pitch sound, we can the retractions are even more, and which indicates whether this indicates that the anomaly, the pathology can go up to the trachea as well as into the bronchus. So complete examination is very important. We should always do a proper head and neck examination in the children, especially if we look at if the child is macroagnatic, which could lead to posterior displacement of the tongue, and this is glossoptosis leading to supraglottic collapse. We should look at the cutaneous hemangiomas. Most of these cutaneous hemangiomas can have associated subglottic hemangiomas, which can present to us as a respiratory distress with stridor. Lymphatic malformations are very common. In my last talk in the NICU presentation, I'll be presenting one case where we had a child with a newborn who presents to us at respiratory distress at birth. And when we do a bronchoscopy, we see that there's a pharyngeal collapse. And later on with the CT scan, we could find out there's a huge lymphatic abnormality in the neck part and leading to airway compression and leading to stridor as well as respiratory distress as soon after birth. And there can be different chest muscles which can cause compression, external compression, and leading to different abnormal sounds. It is very important we do a visual examination of chest wall. As you have seen in the video, there is pes excavatum, which is often seen in children with bronchial or tracheomalacias. And we should always auscultate the sound chest to look for any abnormal sound, especially wheezes or any localized wheezes or focal wheezes. There are different abnormalities which are often associated in children, which we need to look out. Most especially a commonest is Down syndrome. We should look at the whenever we have a child with tracheomalacia or with tracheoesophageal fistula, we should always look for other abnormalities like vertebral anomalies, the anal anomalies. We should look for renal anomalies. In Pallister Hall anomalies, these are basically children with multiple congenital anomalies like polydactyl, syndactyles, and they often present with laryngeal cleft. So if you have a morphologic abnormality which is visible externally, we should always think about an airway abnormality. And of course, Serge syndrome is often associated with guanal atresia. Before going into a bronchoscopy, especially in an intensive care setting, it is very important to have a look at the activity of the child. What is his sensorium? Is the child active, basically? And because any bronchoscopic procedure will lead to some amount of hypoxia. And if the child's sensorium is not okay, and if you're doing a bronchoscopy and if it affects the hypoxia and brings down the saturation, it might affect the sensorium further. And moreover, we should have a hemodynamically stable baby. But even then, if the investigation indicates that a child is going to get help from the scopy or from the, it will help us in diagnosis, even then we have to go ahead. Because this clinical assessment is again important in view of the anesthesis also will be helping you. Because whenever you are doing a procedure, the depth of anesthesia will be basically will depend upon the activity, the sensorium, and the hemodynamic stability of the child. Because with a child who is sick, we have to be, maybe we will not be able to complete the procedure in one go. We have to go in once and then again we have to come back. We have to increase the saturation of the child, prevent hypoxia, and then we have to do the procedure repeatedly for 1 or 2 times. So in those cases, the depth of anesthesia will be decided by the anesthetist based on the activity, sensorium, and the hemodynamic stability. Few investigations that are always required before doing a bronchoscopy, like we need a complete blood count. As we have discussed, we need a chest X-ray, the X-ray soft tissue neck, HRCT is very helpful, and ABG in children who are in the intensive care. The most important saying is you have to always take consent and pre-screening consent. Basically, we should always clearly explain the procedure to the parents. That is very important. And if you are dealing with doing a bronchoscopy with an adolescent child, it is important that we explain the procedure to the child as well. We know that it's not a painful procedure because lungs are not painful, and it is the pleura which is innervated by the pain fibers. So the child is not going to get any pain while doing the bronchoscopy. So informed consent is very important for all therapeutic and diagnostic procedure. In fact, the guidelines from the American Thoracic Society says that the only contraindication for bronchoscopy is that if the parent doesn't give a consent. That is the only contraindication. Otherwise, you can always go ahead with bronchoscopy. Thank you.
Thank you for that very nice exposition on bronchoscopy. And what you said was very important. Sometimes you just want to do the procedure because you have the equipment. So you could justify as to whether you need to expose the child to whatever risks are involved. Although this is one of the better investigations which gives much more return on investment, so to say. Is Dr. Garg around? If you can. Can come on the anesthesia part, Dr. Garg.
I don't think he's around, sir.
Okay, then you carry on with the program.
Right, sir. Right. So our next talk is from Dr. Keshavananda Kaur. He'll be talking on rigid endoscopic airway assessment. Over to you, Keshav sir.
Good morning, sir. Can you see my screen?
Yes, sir. Yes, sir.
We can hear you.
Okay.
We can see you. We can hear you. Carry on.
Okay. So, I'm Dr. Keshan Kumar. I will be speaking about the rigid endoscopic assessment of the airway. So, this is just a picture layout of the hospital which is proposed where I am presently working. So, just to show you. So, I will be restricting my topic to particularly to the lower airway evaluation. I will be excluding the nose and nasopharyngeal examination. So the rigid endoscopic procedures will be, from supraglottic to till the trachea and the bronchus. So my talk will be limiting to the basic procedure involved in the rigid endoscopy. First, just as the equipments have already been discussed, so what particularly important for us to use in rigid endoscopy, because I will not be discussing the conventional bronchoscopes. I will be discussing is the telescopic examinations. So for the telescopic examination, we have our 4 mm rigid nasal endoscope, and we can also use a 2.9 36 centimeter rigid bronchoscope for a older child. So the laryngoscopes, the Miller and the Macintosh varieties, they have already been discussed, and a proper recordings and imaging system, the visualization system we have to have, so that we can have a proper documentation of the things. The anesthesia part has already been discussed, but I will just briefly go through it. For the rigid endoscopic evaluation, we will be requiring obviously a general anesthesia, and we'll be needing the patient to be spontaneously breathing. So preferably, we prefer our anesthetists to use the inhalational gas therapy, which is sevoflurane, or it may be sufficed with propofol or ketamine if necessary, because this gives ideal settings. Because for the spontaneous breathing, we will have to be very short in our examination. We cannot have much time over there, because we'll not be putting any tube inside. So what this is a very quick in and out procedure with adequate sufficient time for the observations. So there must be a very symbiotic relationship between the anesthetist and the ENT surgeon, because before going for the procedure, if there is any conflict in the situation, it has to be sorted out beforehand. Because on table, if there is an conflict, it may lead to a catastrophe. So use of a 10% lignocaine spray, as it is as our Dr. Monier doesn't recommend using a 10% lignocaine spray to see the supraglottic area, because this may compromise the muscle tone over there, leading to a false sense of giving us the airway obstruction, the false sense of collapse, which may produce because of the lignocaine spray. Now the position. As we see, there are 3 axes in a child, which has to be aligned near in the same plane, so that we can have a common axis to visualize the airway properly. The oral axis, the pharyngeal axis, and the tracheal axis. So all has to be positioned in such a way with a small shoulder or under a neck roll, which gives a proper alignment of all the 3 axes. The mouth opening. Before introduction of the laryngoscope, there are 2 ways we can open the mouth. Is a scissors technique, which is usually used for the older child or an adult, with the thumb in the lower jaw, with the index finger retracting the upper jaw. But in this infant or a small child, you can use an index finger just between the tongue and the palate, just to pull it towards the head end. So this keeps the tongue away before the insertion of the laryngoscope. So this is the way how we should be holding the laryngoscope. Usually for children, the laryngoscope has to be held near to the blade, and particularly in a pen holding manner, because this gives a proper angulation and proper pivot for the lifting up the tongue and the epiglottis, rather than holding in a, but in an older child and an adult, it is the other way around. So the technique, in particularly, like as discussed earlier, there are two types of blade which has to be used, which can be used. One is the straight blade, that's the Miller blade, and the curved, the Macintosh blade. So as our anesthetist, Dr. Daisy and Parikshit has already spoken about that, it totally depends upon the comfortability of the surgeon and the anesthetist to use whichever the blade. But ideally, it is recommended that if we are examining a child which is less than 6 months of age or a neonate, a straight blade is used because of the anatomy, because the epiglottis is very flimsy in the infancy, so which is the straight blade gives us a better lifting, better view of the larynx. But in older child, we can use a Macintosh, a curved blade. So as we know, the laryngoscopes, the laryngoscope, before inserting the telescope, the laryngoscope has to be inserted. So the laryngoscope, it is there are two ways we can insert. One is either the anesthetist can help you in positioning, inserting it and positioning it in the place, so that and you can take over later on, or you can yourself go directly using the laryngoscopes. So as all the laryngoscopes are made in a way that it has to be inserted from the right side of the oral cavity, and it pushes the tongue towards the left side. So it has to be always held in the left hand. So it is never the other way around. So once it is placed, so the laryngoscope here, the sizes according to the according to the age of the child, the size has to be chosen. In cases of like in a small child, there's a Miller 1 blade in neonates and infants, and Miller 0 for preterm neonates, and 00 for the very preterm neonates in less than 1 kilo. And in cases of more than 6 months onwards, then we can have a Mac 2, Mac 3 according to the age. So once the laryngoscope is in place, so there is the movement of the laryngoscope is towards the angle which is pointing here. It is said to be towards the ceiling, at the point at the junction of the wall and the ceiling, the front of opposing wall and the ceiling. It should not be pivoted on the upper jaw. It is always in a outward pull direction. So this is on this picture, we can see here the straight blade is used. The straight blade, the purpose of the straight blade is to directly lift the epiglottis away from the larynx. And with the Macintosh, the blade can be put under in the vallecula, and we can see the larynx with gently lifting the base of the tongue. So this is the glossoepiglottic ligament, which while using the Macintosh, this ligament gets pulled up, then keeps the epiglottis falling into the view. So I will just show quickly a video of how we go about. So you see, it has to be inserted. Sometimes here we see that the handle of the laryngoscope in a very small child sometimes may hit the chest. So it may be difficult for you to go directly in the same position. So we have to curve the blade ideally towards the left side, and then you tilt it towards go in. So once we are in, the 0-degree telescope is advanced, and we can see Here we can see the glottic movements. The spontaneous child is spontaneously breathing. We can see the areoepiglottic folds, how the normal anatomy is, how the epiglottis is behaving. This is the supraglottic examination. And in a similar way, we can go beyond the larynx for the tracheal examination. We can see this is a case where there is a presentative stridor. There is a laryngomalacia here. The areoepiglottic folds are foreshortened and they are all falling down into it. So this is how we enter into the larynx. But at this point, we have to be very sure that we should not be touching any of the mucosa here. So the moment, so we have to be very quick and we have to be very sure that we don't injure any of the mucosa, because any slightest injury or happening over there may cause a profuse edema over there, or a bleeding, which may be catastrophic. Either we may not be able to intubate, and that in such cases, if there is a laryngospasm over there, we will not be able to intubate sometimes. So that's it may end into a catastrophe. So you have to be very careful not to touch any of the mucosa. If there is slightest change in the movement or if the patient is coming out, then we have to be out. And we can again go for bag and mask and then again go for a second assessment if needed. So we'll just show a video here that how this laryngospasm can cause a trouble during this examination, which has to be completely avoided. So if there is too much handling of the tissues over there and with inadequate laryngoscopy has been performed, in that case there may happen a certain spasm over there, which may lead to a complete closure, and we may not be able to do anything over here. So in this case, we should not be touching it. Either we can come out and we can go for a bag and mask and wait for the child to settle down. So the choice of telescopes and when to use and which telescopes to use, it depends upon according to the age and that area we have to assess. So for the supraglottic, glottic and subglottic areas and trachea in a small child less than 1 year of age, 4 mm telescope in nasal 18 centimeter telescope is ideally, because a newborn child, the airway size is approximately 3 to 4 mm. If it's a preterm child, then we cannot do assessment with a 4 mm telescope. Rather, we should go for a 2.9 mm scope. Either it may be a nasal scope, because 36 centimeter for a neonate or a preterm baby will be quite longer telescope to handle, because it's a very thinner scope, and with the increasing length, there are high chances of injuring the telescope and also the surrounding structures in the trachea because of its movement. Thank you.
Once again, a very nice demonstration. The only thing that we do slightly different is just to avoid the laryngospasm is we use about 2% lignocaine. I don't think it really comes in the way much, but then and then you introduce the instrument, because one is of course the laryngospasm, and second thing is there are some children who go into bradycardia when you touch the epiglottis or the glottis. Very nice pictures, wonderful talk. Thank you very much.
Thank you, sir.
Dr. Raman, just to add, Dr. Kesav was with us just till a few months back. He left recently and joined the hospital that he has showed on the picture.
Beautiful. It looks. Any job there for me?
He was a core member of our party.
I'm applying for a job.
Sir, please.
That's wonderful clinical material.
Yes, sir, thank you.
In that place, that is an underserved area. Hats off to you people. I mean, your future is bright as far as the professional satisfaction is concerned. You're going to get more and more cases with good training, good equipment. God bless you.
Sir, before
Thank you.
it comes in, I'd like to mention for the benefit of our viewers who are around that Dr. Raman, as a young Air Force doctor, was posted in Jorhat in Mariani Air Force. And he tells me always that he had a great time there at that time.
Absolutely, absolutely. So I can always come back there after retirement. One always goes home after retirement, so I can come and make Assam my home.
Sure, you're most welcome.
Okay, proceeding ahead with the next talk. This is from Dr. Biswajit Gogoi sir again on flexible endoscopic airway assessment. Over to you, sir.
Good afternoon, sir. This is mostly my last talk today. So excellent presentation by Keshav. Initially, we have thought rigid through the rigid endoscope, we can assess not the dynamic or physiological airway, but his video shows how we can assess with the rigid endoscope also the dynamic physiological airway. And that's credit goes to again. I want to express my gratitude to again Dr. Utpal, who is associated with all this rigid endoscopic procedure, and how beautifully he had induced a style and maintained a spontaneous. And he always asks me, Biswa, I'll give you 30 seconds and you do whatever you want to do and come out. That's his approach. Now I'll go to flexible endoscopy. So flexible, I have learned, these are my two guru actually. I have learned from Counsel, adult bronchoscopy. He always give me the sunset of his own private patients. And he initial days, he always give me, please be sure, just remove the bronchoscope, not the introduction of the bronchoscope, and try to maintain in a panoramic view, and also maintain how the patient cooperative till you and come out to the nares. Then that will give you, that's how he has teach me. And luckily I have got, I met Vijay Shekharan in one of our workshops. Then before that, we are not doing regularly flexible bronchoscope, pediatric bronchoscope basically, and we are doing it adult bronchoscope with Counsel. And that workshop, this eye opener for everybody, like part of and for everyone who was presented at that workshop. And we have seen how a 1 day style, 2 day style bronchoscopy can be performed. And I still remember in auditorium, he has performed mostly 5 or 6 bronchoscopy without any hiccups or without any catastrophe. And this is the picture from that workshop. And luckily, thanks to E.V. Raman sir once again, because he invited me. I don't know why sir invited me, and I still have the invitation. And he invited me as a moderator of one session. That before that, I don't know anything about the P of the pediatric airway. And that workshop, I have attended that was my first certified or official workshop I have attended in terms of pediatric bronchoscopy. And it was really, I have all, you can't imagine, sir, I have all these Mahesh Babu and every faculty still in my laptop. I can share with the juniors. It's a very excellent lectures. And the indication of the flexible bronchoscopy, as Partha has always mentioned here, I mentioned mostly all the indication. I'll not go regarding the indications. But I emphasis here on these are in case of from the impressive was difficult in extubation, like it's also in a difficult decannulation of the tracheostomy tube. Through tracheostomy tube, we can do endoscopy because my talk is flexible endoscopy basically. And recently we have experienced that we should do all preoperative cases of tracheoesophageal fistula. So it is not the standardized child who required only endoscopic evaluation. It is the issues with aspiration, and because that area is not issue with respiration actually. The issue is swallowing and all this physiological thing, and also persistent LPR and GERD. Therapeutic experience we have like removal of thick mucus plug, treatment of persistent atelectasis, and also in case of we have a difficult intubation, balloon dilation for laryngotracheal stenosis. Foreign body removal, we don't prefer as a ENT surgeons, but the literature has people have experience of Dorme-Bursket, and it's also very helpful in case of a distal foreign body to bring the foreign body to the main trachea, and then with the help of the optical force, if we can remove the foreign body. And people have also experience with a bronchoscopic laser. As such, we have not that much of experience. This is how we prepare the child. Basically, we do most of the diagnostic bronchoscopy as an office procedure. We have a dedicated endoscopy suite, and this is how we can prep the child so that he can't move his basically limbs and hands. And before going to proper bronchoscopy, we have need a checklist. All the pulse, the basic pulse rate, respiratory rate, SpO2. You need a very good pulse oximeter, PCO2, blood pressure, and all leads should be in properly fitted, and need a one good IV lines. And these are the pre-medication we use in the office procedure. Nowadays we don't use atropine, and we use ketamine 2 mg per kg body weight and midazolam. Generally in office procedure we don't use fentanyl and propofol. If you do bronchoscopy in you require good sedation, full paralysis, then in OT we use fentanyl or propofol in presence of anesthesiologist. The first, basically we use ketamine and midazolam in presence of interventionists, mostly with a Parthada, Dr. Parthavara. And we use the topical anesthetic agents like lignocaine jelly. This lignocaine jelly not only helps in anesthetize the mucosal aspect of the nares, also it helps in the lubricant. It lubricant the scope, and we use 2 to 4% of xylocaine as a spray, and the technique is spray and go. And but it should be mind that the lignocaine spray should not be more than 8 mg per kg body weight. Ideally, it should be 4 to 5 mg per kg body weight. So let's move the actual procedure. This is how this is the not simulated. And we always mention the head end of the child. And this endoscopy we have performed during COVID era, actually. That's why we have taking all PPEs and COVID precautions, try to limit as much as cells. And this is how putting the xylocaine jelly, optics ready, recording device ready, and this is the endoscopy through endomax. Difficulty with the endomax is I have found one difficulty. Sometimes if you fitted the endomax very tightly, then the scope there's a angulation. There's more angulation of the scope. So I don't know. Most probably manufacturer will design later on to have a good angulation for the scopes. And this is how. This is the station actually I want to share, and not going to the endoscopy procedure here. And this is the interluminal finding. That's how we see the turbinates, and going, you have to see all the mucosal lining. If there's a congestion, if there's a more crusting, then you can think about the organogallomatosis or cystic fibrosis like that. This is the nasopharyngeal area. We have to always look for the palatal movement, because movement because sometimes in lower cranial nerve palsy or lower cranial nerve palsy, there may be impaired palatal movement. Then that's how we reach the supraglottic area, lingual tonsils, epiglottis. Then this is the area. And here we always put as 4% spray and we wait for few minutes. And again, we overview of the supraglottic area. And then this, again, introduce the bronchoscope in the mostly posterior 1/3 of the glottic and in the maximum expiration. And after entering the trachea, and this is the lowermost part of the trachea, there is a carina, and this is the right and left bronchus. There's almost tracheal ring, almost 280 degree of the tracheal ring can found. We can see the movement of the wall of the trachea. Is any kind of secretion. This is a spray and go. We should always not on the glottic area. We should every time when you enter the lower trachea, we also try to give a spray so that this lower trachea again exercise and place cough and maybe then this is the secondary bronchioles. And since this has only two direction, either up and down, so we have to get another direction at the level on the left hand of the scope at the level of the nares, and so that we can get the third direction. But don't try to get the third direction. I generally told my juniors it is a XYZ direction because if you move, but if you bend very much, the bronchoscope gets teared. The fiber gets teared. So this is the carina. And when it comes out again, we should always check again what is the airway, and it should gradually come out. Let's check the situation. Let's check the pulse. Pulse is another important. Everybody concerned about the situation, but in a children, bradycardia is more dangerous than the pulse. That's how we can come out. So, and another most important in flexible endoscopy is a concomitant pathology. We should always look for, you should not be excited. During initial days, we always get excited. Wow, we get this finding. Just come out. Okay. And we go give the message to the parents that your child is, this is here, you can appreciate. This is a velopharyngeal sphincteric region. Then he has a laryngomalacia. He has a laryngomalacia. So we have exception on laryngomalacia. That's why I'm not going to describe all the different type of laryngomalacia. It is a tubular variety, type 2. Then we introduce the bronchoscope. Then this is one finding. Let's see what we can. That's why it's need a complete airway assessment. I don't prefer FOL, fiber optic laryngoscopy, only for the in case of a steroidal only upper airway assessment. Now that I have learned from Sandhu sir also, we need a full assessment, not only the airway, also you should routinely do the gastroscopy also. So let's see what this is here. So one is a laryngomalacia. Then we can found in the trachea, he has a tracheomalacia. So, and also severe bronchomalacia. So if this patient has on bronchodilator or something else, so that maybe aggravate his symptoms, and you can appreciate here the severe tracheomalacia along with bronchomalacia. So his full diagnosis is type 2 laryngomalacia with associated tracheobronchomalacia. So we should always rule out the concomitant pathology. Here we are doing, that's learn how with our experience that how we should do because this cell has a decannulation issue, then how to perform endoscopy, flexible endoscopy in case of a tracheostomy cell. It's a very interesting cell, and he has failed to decannulate. We have failed to decannulate, and he has through many centers in India, and they have not found any cause. What is the cause of decannulation? And then we did the endoscopy, flexible endoscopy in full awake. We are not giving any medicine in that cell, but every center when I have going through the prescription, we have found that they have sedated the cell. Then we should remove the tracheostomy tube if the cell is tracheostomized during the evaluation. That's the most important. Then neither we can miss the supraglottic airway, like a supraglottic tracheomalacia that caused by the tracheostomy tube. Or another thing, we can completely assess the supraglottic airway, particularly vocal cord movement also, since the airway exhales through the tracheostomy tube. That's the take I have learned from our experience, that always remove the tracheostomy tube if there's issues with the decannulation. So that's another interesting. If you see the dates of this bronchoscopy, here is 18th and here is 20th. Same cell we have did bronchoscopy twice, because this was on 18th. This was on 18th. So you can appreciate there is not as such vocal glottic closure. So we are confused that he has a vocal cord palsy. As a whole glottis is moving, but there is no total adduction of your vocal cord. So maybe we thought that it is maybe due to over anesthesia or over sedation. So what we did, we called the patients, and next after 2 days, then we did evaluation, not putting too much of medicine. Then we have found that he has a no vocal cord palsy. So you can see. So that's why sometimes it's required in airway, not only the diagnostic. When you are in repetition, sometimes we have to go, as counselor has told in a introductory talk, we should review our video also, what happening, and the full part of the unedited video, not the recorded video, edited video, which is always go through it. This will be a take. So already we have covered all these things. In case we have a resit already, Kassav has covered. And in case of subglottic stenosis, all these things, the 1 mm silent endoscopy comes to also help, is a visual part. And we have generally used 2.8 scope. 2.1 is good for neonate. And if we can't do anything, neither is it flexible, then we can do a partial bronchoscopy. That I'll try to cover in radiology part. And it's good for, but the issue is if there's a severe mucus retention, then partial bronchoscopy again give you some kind of polyp or some issue, and they don't comment on mucosal aspect. So another important is a retrograde endoscopy. If can't negotiate any endoscope from superior aspect, we should go. If it is silent tracheostomy, we should always evaluate from below. So this is the most probably last video of endoscopic evaluation, and we are not that much of experience regarding GI scopy. And this is a 4-year trial with aspiration. Then we did gastroscopic evaluation with the help of that I have described before, 5.9 mm scope. This is the esophagus. Because very beautiful demonstration in Calcutta from last Phonocon by Sandhu sir, and he has found his child the eclasia cardia, and the child he has demonstrated. So, but we are in the early phase of the gastroscopy, and also fish. You can do also fish with the help of this endoscopy. And This is how we do OR. Already I have mentioned. This is with the help of and flexible endoscopy. You can do submerged intervention, like we are putting in this T tube in case of in a tracheomalacia case, in a supraglottic collapse case, and that's how the endoscope can help everything. And this is a style you can appreciate. Here is a tracheocerebral fistula. So it is always in the posterior wall. No. This is a style who operated once by just a surgeon for the tracheocerebral fistula, but he has a permanent link. Then we have, during the necropit, we have evaluated. So it's a dynamic procedure, as we are doing mostly in the office base, and generally we now don't give too much of anesthesia, and we can. It is the advantage of a maximum length of airway. According to book, it can go to up to 5th level bronchi, but we are experienced till 3rd level. And you can do as a mobile unit. You can, from endoscopy, you can, the whole unit can shift it to your PICO and NICO, and slight anatomical sense we can negotiate, which is not possible with a rigid sometimes, and it can take part in interventions also. And most interesting that we can go through. When I prepared things, I got the idea that we can go maximum approach. And these are complications. Generally, it's a very less complication, but these are the complications we should take care, particularly bradycardia, local anesthesia toxicity, temporary hypoxia. And definitely it's a solid tube. Definitely there will be hypoxia, but at a heart level, the hypoxia we can maintain, we can resuscitate. That depends upon the experience of the whole team. And when you take a ball, all these things, the infectivity may be some issues. This is a very good article, and this shows the flexible bronchoscopy is a safe procedure who have a less than major complications. And we have a good demonstration of today how we can introduce the airway with the face marks. And I have found this article very interesting because this is the first article I have learned that there's a 6 route where we can do flexible endoscopy transnasally, via face marks, via laryngeal marks airway, via endotracheal tube, via tracheostomy tube. These are all the 6 route where we can do flexible endoscopy. I don't know, there may be more approach will become. And this paper has a very nice which route is good and where advantage and disadvantage. And thank you so much. It's driving in a airway, flexible endoscopy, and it's a very good technique. I hope everybody will find. Thank you. Thank you so much, sir.
Biswajit, congratulations. Excellent talk. Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Yeah, Biswajit, excellent talk.
Thank you, sir.
In Air Force, it is told when the instructor teaches the student pupil how to fly, and then the student pupil catches up and does better than the teacher.
No, sir. I am very much thankful.
Excellent.
Yeah.
I've seen your progress over the years, and you've got a wonderful mentor in Dr. Gautam Kond also.
Yes, sir. Yes,
you've got an excellent environment. Please flourish, do very well. I just want to, if I have the permission.
Yes, why not? Sure, sir.
I have. Yeah, 1 or 2 observations and a couple of slides, if it's possible. I'll ask Deepa to present. Not that you've not covered, but just to reiterate a few things.
Okay,
Dr. Gautam, do I have your permission?
Sir, you don't need any permission.
No. The person who's conducting the program, I need to. So most important thing in a flexible scope is, of course, you already said. I'll just go through my comments and then we'll start with the slide. One is synchronous lesions. So don't be very happy that you found one lesion and stop looking at the other. The second important thing I want to say is when you introduce the scope, yes, you're introducing the scope with some tension, trying to look for the right openings and pushing it inside. But very important is when you're coming out, take your time, keep looking at those structures again. It's possible that you missed it when you introduced the scope. We found many lesions like that. Then the other thing Biswajit already mentioned was the retrograde, which through the tracheostoma, etc. And the other important thing you did mention was regarding the removal of the tracheostomy tube. You must remove the tracheostomy tube and then have a look. Those dynamic collapses you'll miss. And yes, esophagus, very important. You're already inside. And there's another very important reason why you need to look at the esophagus also. Most of the cases of clefts are associated, at least 20% association between clefts and tracheoesophageal fistulas. But unfortunately, we don't have good communication or more awareness amongst the pediatric surgeons. So what happens is they do the tracheoesophageal fistula repair, and the child still has a problem, and they feel that their surgery hasn't gone on well. But the child may have a coexisting laryngeal cleft, which has to be looked for. The association is as much as 20%, and we need to take care of it. So I believe if a child is not doing well after tracheoesophageal fistula surgery, definitely an ENT referral to look for laryngeal cleft is very important, especially because laryngeal cleft can be missed by us even with a flexible scope. Child requires a rigid scope to assess, to see whether there's a cleft and to assess the depth of the cleft. That is an important point. Then sometimes it's very difficult. We say the vocal cord palsy. I know it's not so easy to diagnose sometimes. So what you do is, one is of course you introduce the scope, have a look. When you come out again, you have a look, and thirdly, you have the recording. So go see the recording with your friend, and I'm sure they might give you, your team member, recording and viewing that again, maybe even in slow motion sometimes, will be very useful. And one of the places where we do not make correct diagnosis or we are confused is when we have vocal cord palsy, whether it's bilateral, whether it's unilateral, etc. That's an important point, I feel. Thirdly, regarding, sometimes you have to, when the child is crying very much, and then you're not able to assess the amount of, regarding the collapse, laryngomalacia, etc., etc., a very minimal amount of sedation just to make the child sleep. Otherwise, the child is constantly crying and the collapse may not be obvious for you to plan the surgery. So see that these are my limited points. And the other one, of course, I'm sure Biswajit is going to start doing this more and more, is fees with the flexible scope. Return on investment is always much better when you do more and more of usage of the instruments that you've already, invested on. Of course, you need a help of a speech and language person very much, and that's the other way to increase usage and of your instruments, because many of these children who keep coming to you will have swallowing disorders, swallowing difficulties. So with your permission of the chairperson, I'll just go to the 2 or 3 slides. The instrumentation you've already covered. Deepa, you can change the slides. So that's, I think most of the instruments are there, but only important thing is keep all of them ready, whether you require it, you don't require it. I remember Dr. Gautam mentioned in the first lecture saying that have a tracheostomy tube set ready there. Don't go search for it later. Have the appropriate size tracheostomy tube, one size smaller also. These are all for safety. Then we also, this is all thanks to my fellow Dr. Deepa. You see, you have the benefits of having somebody with you. So you learn, you teach, and you learn more. So this is what she has done. She's done a checklist of these instruments which have to be kept in the theater. Otherwise, we find that the nurse is running around looking for various things. And the very common sense things, you have a bowl with normal saline, bowl with Savlon, lignocaine jelly, Kinocort steroid injection, everything ready, 4% lignocaine spray. And then you have 2% nasal drops sometimes when you do a flexible scopy prior to whatever you're doing. Then the airway instruments, direct laryngoscope, inflation device, tracheostomy set, tracheostomy tube, same size, one size lower, laryngeal instruments. Do a checklist and make sure everything is there. I don't want to waste your time anymore. Recording system, yes, very important. On the day you have a very rare case, invariably the recording system will not work. All these things do happen, Murphy's Law. So please make sure of all those things. Another lovely instrument which I really like is the suction tip with a, it's got an olive tip in the end. It's very atraumatic and it's extremely useful. And again, I mentioned it earlier also, make sure the suction is off when you're introducing the suction cannula inside. And when you come out, you keep open it. And when you're near the cords again, you can close it so that you don't create trauma during that process. And the L probe is very important in for the laryngeal cleft. You need to go and assess the cleft. It's very important. You can use that. And we'll go to the next slide. I think this is done. Yeah, Parsons, you already showed that. I find this quite useful in the sense you can introduce the instrumentation in the last picture. You can see you want to introduce any instrument, you can put it from the side. That is important. Sometimes when you want to size the subglottic stenosis, you can take an endotracheal tube, introduce it through the side so that you've got enough space. But the disadvantage with this is when you're trying to do your procedures, the tongue comes in and blocks the area. So the other instrument which I really like is the next slide. The Benjamin Lindholm instrument, absolutely perfect. And on the right side, you have a clip-on light carrier. This is very useful. Biswajit, if you don't have it, get it, because it's got a beautiful light carrier. You just clip it on to any of the scopes. It can be used for any of the scopes. And lower down to the picture is the L-shaped probe, which tells you about the cleft. And this is the suction, the tip. I hope you can see it. The tip, you can see that it's olive tipped. It's not the sharp tip, so that it doesn't cause any damage. And sometimes child is spontaneously breathing. There could be some movement and you can hit the walls. And of course, the chest piece, you all know about it. Next one, slide. Yeah, there's another very nice instrument, of course, slightly going out of fashion, but I think you should know for the sake of history and also for the sake that this instrument is available. These are the Savary-Gillard dilators, which will be in your gastroenterology department. So sometimes when the subglottic stenosis is too narrow and you want to use a balloon afterwards or something, you can slightly dilate with this. They are very friendly. The only problem is they are long. So sometimes what happens is when you try to do the dilatation, on the left side picture, you can see the Savary-Gillard going in. And go back to the original Savary-Gillard slide. Oh yeah, it's a video. Okay, wonderful. So you can see the Savary-Gillard there. There it goes. That's the subglottic stenosis there. So the problem with the Savary-Gillard is sometimes when you want the adequate length, it might touch, in a pediatric case, it might touch the carina. So be careful about that. Go back to the Savary-Gillard. Yeah, this is the one. It's gently tapered, if you can see. And who was Savary? Savary was Monier's teacher. So it's all coming from the same place. So Savary was the professor before Monier. And you know, Monier's book is like a Bible. You said it. It couldn't have been well edited. Every single word, as you said, Gautam, is important. And like Biswajit, I keep reading it 100 times and I keep forgetting it 100 times. So I think you should always, all of us should have it till the next edition comes, hopefully. So that's a Savary-Gillard I wanted to tell you. Next we go to... Yeah, so these are the carrot bougies, we call them. It's called the Pelling-Jackson esophageal bougies. So in the top, you have a wire kind of a thing, and these are the carrot-like things with an olive tip. They're also very useful. Sometimes these instruments can be used sometimes pre-operatively, sometimes post-operatively when you have small areas where you feel a little bit of enlargement can be done. But this is, all these dilators are gradually going out of fashion because of the reason that they cause some amount of trauma. So the latest way to dilate things is, of course, the balloons, because they are less traumatic and they cause, axial breaks in the stenotic area. So that is the advantage. And I'm sure you're having a whole series. Somebody else is going to talk about all these things, but I thought I'll introduce the concept. On the right side, you can see the balloon just going in. Make sure that the there's no trauma to the vocal cords, and the balloon is inflated. These are all in such a way that the ultimate size of the balloon is fixed, so that it doesn't go beyond that. And this is an entirely different topic. I'm not going to touch it today, but just want to make you aware of the fact that what all we talked today, this is an extension of what wonderful talks given since morning. Position, this we won't do. Anything else is there? This is all covered. We don't want to waste anybody's time. Okay, that also. Oh yes, microdebrider and coagulation and CO2 laser. These are the adjunctive things that we can use. My only worry about both laser and coagulation.
ये पैसा भरने का है, लाइट का बिल भरने का है, घर का लैंडलाइन का बिल भरने का है.
We tend to overdo these things at times. Okay. I think we are almost done. And of course, rigid, yeah, all this is already covered. Yeah, nasopharyngeal insufflation technique also, I think, has been covered by the anesthetist. Yeah, next. So you get a lot of time instead of rushing in and out if the proper anesthesia is given. Yeah, we'll skip all this. We don't waste people's time. Okay, that's all done. Next. Yeah, I mean, this, I think the last line is the most important amongst all these things. And I think you already have achieved wonderful team you've got, but I always try to show off my center. So the latest addition to our team, I'm sorry about this. This is just to make you people also to reach that level. We have a pediatric gastroenterologist now with us. So, so it's my good fortune that everybody has been helping me. So thank you very much, Gautam, for giving me this opportunity. Like I said, that Biswajit starts doing more and more work, I'm going to shine in his borrowed glory.
Thank you, sir. Thank you. Your words are all so very important. You have summed up everything in a nutshell so nicely. In fact, talking about the dilators, the place where I actually primarily work is called Nightingale, where my boss, Dr. N.K. Agarwala, he passed away in '95. Oh. He had got these Savary-Gillard dilators as well as the pilling. He used it mainly for esophageal post-caustic. Right. Then we have used this for our airway work now. We don't get so much of esophageal narrowing nowadays because of, and most of the time the esophageal narrowing is handled by balloons, as you said. So it's been so nice. Sir, there are a lot of queries and Sanchita will guide you regarding the queries. And I think we will unmute the people who are on the Zoom and we will pick up the questions from there. So Sanchita, please come in.
One little request, Gautam, before we yes, go ahead. I want a little pass to trespass without any permission on your subsequent days. I'm going to come and watch you do the other episodes also.
Sir, you are welcome. You are welcome for all the days. And sir, you could have also put up the slide of your evening's webinar also. Who are interested in airway could have, those who don't know could have joined in the evening webinar.
Oh, sure. You're welcome. I'll just see whether Deepa can do that by the time we finish with the questions.
Yeah. By the time we discuss, he can put it on. Yeah, Sanchita, please come in.
Yes, sir. Thank you, sir. So actually, I would like to apologize about the last session which was scheduled today. It was a live bronchoscopic pediatric airway assessment, but because of the recent COVID scenario in Guwahati, this region has been declared as a red zone now, and the patient is unable to commute, unfortunately. So we will shift that session to the last day, 19th. We'll try to make it that. And now we have, I think, almost half an hour or a little more to take up the questions and go for the discussions. I will help you with the questions, sir. The first question is from SB Pukon, sir. He's asking about the advantage of virtual bronchoscopy over flexible bronchoscopy.
Biswajit,
if you are around, let me just add this before Biswajit. The basic advantage is that there are many situations when you have not seen a foreign body, when nobody has witnessed a child having ingested a foreign body. The parents have brought the child to the pediatrician for a chronic cough or recurrent pneumonia or things like that, where they wouldn't like an interventional thing happening immediately. They wouldn't like to put the child under anesthesia or wouldn't like the child being scopied. There actually virtual bronchoscopy is a big help. You can have a radiological assessment and see whether there's any foreign body actually blocking, especially a vegetative foreign body, because a metallic could have been picked up on a plain X-ray as well. Biswajit, you can add.
Yes, sir. Virtual bronchoscopy is a great tool. It's complementary to endoscopy actually, and we can assess the whole airway from upper airway to lower airway, the bronchioles. And another biggest advantage is that we can know if, suppose in a case of a stenotic, already you have mentioned foreign body stenotic, then you can know the level of extension of the stenosis. Particle extension of stenosis in a virtual bronchoscopy. In that scenario, if the baby is not tracheostomized or then you can know you can't negotiate the scope. If you can negotiate the scope also, they may deteriorate rapidly in that kind of scenario. But you can't give anesthesia also because he already is stenotic. In that kind of scenario, partial bronchoscopy helps lots, sir. If Raman sir can add anything, sir.
Nothing special. I mean, whenever you're stuck, I think it helps. And then sometimes when you're not able to fully evaluate, for example, the multiple, one is complete tracheal rings. It's very useful when you want to plan surgery.
Yeah. Yes, sir. Yes, sir.
Sometimes external compressions. These are the where it's absolutely invaluable. And when you have long segment stenosis, when you can't go below a particular level to assess it, it's confirmatory. These are the areas where it helps.
Exactly. It's almost dynamic. If a good radiologist is there, they can do almost a dynamic evaluation of the full area. But in case of tracheomalacia also, they
to be used very selectively because of the radiation exposure.
Yes, sir. Exactly, sir.
And the second practical difficulty is when you move a child with respiratory problems to the suite, you don't know what's going to happen there. So you have to stand there with, with a crash cart. So be very careful about that part.
Exactly. Next question.
The next question is again from Dr. S.B. Fukon, sir. He's asking Dr. Patho Bora, there are three parts of this question. First, how will you know a biofilm has formed? How will you overcome it? And what organism is involved? Patho, sir.
Okay. Thank you, Fukon, sir, for the questions. Thing is, we need to suspect for development of a biofilm. And because as I have said, when we do conduct a leakage test, and if we find that there is a leak, there is always a chance that there could be a development of a biofilm. And if you are not following the protocols of disinfection or sterilization, and there is always a risk of development of biofilm. See, most of the times whenever we're doing a scopy, especially in a child with, suppose it's a child with pneumonia, a child with cystic fibrosis, their lungs already has microorganisms which have already developed there, and they've already colonized there. And these microorganisms like Pseudomonas aeruginosa can easily penetrate into the scopes. And this organism, basically Pseudomonas, which is multi-drug resistant at many times, especially in children with cystic fibrosis or ciliary dyskinesias who have been having this prolonged infections or bronchiectasis, they usually make a film over the bronchoscopes. How to overcome it? I think we need to strictly follow the protocols for disinfection and sterilization. If you suspect that that your scope is giving infection to your kids, then of course you need to, after proper disinfection, we need to do a ethylene oxide, what you call it, a sterilization, and that's at many times it helps, I think.
As fertilizer said exactly, biofilm also we need a very good high-level disinfectant for atypical mycobacteria. Actually, this is a very so it may contaminate the next patients also. So we have to follow all the protocols of disinfectant so that the spores gets disinfectant. As a
Raman sir, would you like to add something to it?
Not really. I think it's been covered as to how to avoid it and give the right kind of treatment for that. Anything that you keep in for a long period of time, a T-tube or even this thing, what's it called, laryngeal stent, all these potential problems with biofilms are always there. So the best way to do is take adequate precautions, and secondly, of course, treat if required. And many times these days, especially when you have a stage 1 surgery which has failed and then you want to repeat it, all these things are very important to select the right patients, right type of surgery, and right time of intervention. So it's very important. Don't be in a rush to do and have another failure.
Right, sir. The next question is also from S.B. Pukon, sir. He's asking about the assessment by Malampati score. He's particularly asking Dr. Parikshit, sir. And is the pulse oximeter used in children same as like that in adult? Parikshit, sir?
Hey, hello.
Yes, sir.
As we spoken, sir. Sir, firstly, regarding Malampati score, it is very difficult to assess Malampati in case of a child because usually the child is not so cooperative as an adult. And at the same time, since in Malampati, we actually assess the size of the tongue in respect to the oral cavity. But then as a child, usually till around 5 months or maybe 1 year, has a larger tongue in comparison to an adult. That is already, we already know that we are in for a bigger tongue there. So, but assessing airway in case of a child is mostly by external examination of the mandible, any kind of defects in the neck, and is the patient syndromic. So these are certain things that we look for rather than going for a conventional airway assessment as we do in case of an adult. I think that answers your first question, sir. And regarding pulse oximetry, the concept of pulse oximetry is similar as to that we use in case of an adult. It is just the probes that we use. Usually it has to adapt to the child. Usually we strap it to the sole of the feet or to the palm of the hand, or there are smaller size finger probes that can be used for a pulse oximetry. I think that answers the questions.
Yeah. Next, Sanchita.
Yes, sir. Okay. If there's no addition to that answer, then I would go ahead with the next question. This is from Dr. Kripamanath, sir. He's asking, what is the advantage of RAE tube in airway surgery? This is again put forward to Dr. Parikshit Hazarika, sir.
Okay. Regarding RAE tubes, these are actually preformed tubes. We have both south-facing or as well as north-facing tubes. The problem with RAE tubes are, since it is preformed, it is a little difficult to assess how far it will go, or how far will it go, or will it go too deep inside, or will it remain a little more proximal to the vocal cords. So at the same time also, since it has a preformed tube, so the problem is it has some bends and curves which may increase the turbulence, or may increase the resistance to the flow of gas in case of anesthetic gas in the child. So usually nowadays we have stopped using RAE tubes as such. Rather we go for our armored or reinforced tubes. Okay. That will.
Sanchita.
Yes, sir.
There is a query here also in the
chat box. Yes, sir.
Chat box also from, well, there's only one query. You can take that as that.
Yes, sir. I have already written that query actually. I'm going sequentially, sir. Okay, the next question is from Dr. Arun Deka, sir. He is asking, do you have pediatric bronchoscope? And if you have, please tell some details about it. I would like to say that we have a whole pediatric bronchoscopy demonstration, which is scheduled for the last day. So I think we can skip the question for today.
Right.
Okay, so the next question is from Dr. Niteshwar Singh, sir. He's asking, what about the clinical and imaging characteristic of laryngomalacia? He hasn't specified to whom he has put forward this question.
I think Biswajit, you can come in. You can take our
Yes, yes.
Sir, for Nitish, we have actually extensive laryngology session. If you go the question, you can discuss the question in that session also. No?
decided to answer it later because we have a whole session on laryngomalacia. So next question is from Dr. Pradeep Kumar Tiwari. He is asking any advantage of using bivona tracheostomy tube. Again, we have a session on tracheostomy tube actually. Can we skip the question then, sir? Okay.
You can Dr.
Okay.
Niteshwar and Dr. Pradeep, what has been suggested that you know the schedule of the next few days. So we will definitely address your questions. If you forget, we will remember to answer your questions during the sessions. Otherwise,
Right, sir. So going ahead with the next question, this is again from Dr. S.B. Pukon, sir. He is asking Dr. Parikshit, sir, again, which airway tube do you use after recovery from anesthesia? And a second question again, in pediatric age group, propofol or dexmedetomidine, which is better? Parikshit, sir?
Okay. For the first question, I'm not sure how to answer. I'm not clear about what sir is trying to ask me. But then maybe it is about if the patient is, if you want to put in the airway after what you call recovery, then we can either go for a nasopharyngeal airway or an oropharyngeal airway, whichever is feasible, because if the patient is deeply sedated during recovery, then we can always go for an oropharyngeal airway, or if the patient is not breathing well, but then is struggling, then maybe we can go for a nasopharyngeal airway. Because if we put in a child with who is mildly sedated, and if you put in the oropharyngeal airway, in that case, may lead to gagging reflex, and the patient may vomit and aspirate. And coming to the second question, it was about propofol and dexmedetomidine, I guess. Both has their own advantage and disadvantages. Propofol, basically, if in case of if you want to use propofol as a sedative, in case of what you call drug-induced sleep endoscopy, it is a little dicey because propofol causes total. If you go for deep sedation, it may cause relaxation of the laryngeal muscle, and you may not get a good study of the airway which you want to, because it causes deep sleep. What we prefer is using dexmedetomidine and at the same time using a little bit of ketamine, because ketamine causes gives us a little bit of analgesia, and dexmedetomidine gives us a bit of sedation, but then it is a little the balance of titration between sedation and analgesia has to be maintained. And disadvantage of dexmedetomidine is it may cause bradycardia, which is can be problematic in case of a child.
If I can come in.
Okay.
Yeah, just adding to Parikshit, actually from a bronchoscopy point of view, whenever you are doing a bronchoscopy in a pediatric patient, what we expect from an anesthetist is that for assessing the airway, basically we need to look at the dynamicity. So we'll ask you to go for a conscious sedation, basically, where we can clearly examine the dynamic airways. Once we have assessed the dynamicity, then we can, of course, if you have to go inside into the lobes, inside the bronchus, where we need to do a procedure, we'll ask for a deeper sedation, where you can go for a, I think propofol would be a better choice from our point of view.
Yes, definitely, yes.
Okay, can I go ahead with the questions?
Yeah.
Okay. Again from Dr. S.B. Pukon, sir. He's asking, is Miller's blade, like Macintosh blade, which is used in adults, also used in pediatric age group? To Parikshit, sir, again.
Oh, okay. Miller, we have already demonstrated, Miller blades are straight blades and are preferably used in case of pediatrics. We generally don't reserve the straight blades like millers in case of adults, because as we have already demonstrated, because miller's blade, you have to lift the epiglottis as a whole, and the idea of lifting the epiglottis is because in case of a child it is floppy and big, so you have to lift the epiglottis at times, but then this doesn't happen in case of an adult usually. And another problem is if you are using the lifting the whole epiglottis in case of a adult, there is a problem of vagal reflex, which may cause lead to bradycardia in case of an adult. So that is one problem in using millers in case of an adult. So preferably I would go for using a miller's blade in case of a child only.
Okay.
Thank you.
Moving ahead with the next question. This is from Dr. Keshavananda Kuwar, sir. He's asking, what should be the size of cuff connector for cricothyrotomy assembly? Dr. Parikshit, sir, again.
Come again. What was the question?
Yeah, what should be the size of the cuff connector for cricothyrotomy assembly?
Okay, actually, cricothyrotomy, we are not so adept in doing it. We haven't been practically, because we thankfully till now we have not had the need of doing it. I think the best person would be an ENT surgeon who can.
No, sir. So I was asking specifically the assembly you have shown. You have put the connector on the 2cc syringe.
Okay.
Because not all the correct connectors can be connected to a 2cc syringe. What is the size?
Okay, it's 5 basically. A 5.
It's a 5 size tubes connector.
Tubes connector. Yes.
Because other who are either would be very small or will not be able to put it in. Okay, thank you.
Any other comments, sir?
Yes,
okay, so,
that is.
Okay, so I'll move ahead with the next question. This is from Dr. Kudush Ahmed, sir. He's asking, could virtual bronchoscopy replace actual bronchoscopy itself? It's an open question.
Do you want to look at the shadow or you want to look at the person?
I think I'll pass that question to Dr. E.V. Raman, sir. You can give the answer, sir.
Yeah, see, virtual bronchoscopy, the problem is that small images are reintegrated by the computer. That is one thing. So it can give you some areas of approximation. When you do a regular bronchoscopy, you have absolutely, total control of the whole area and you're looking at it. It can never replace. And I have a case, a child who was about, I think about 3 months old with 2 hospital admissions who came to us. And I couldn't diagnose the condition actually. I did the 2 bronchoscopies and couldn't diagnose the condition. The child would get was admitted in another hospital. Finally, the child came to our hospital with a similar kind of respiratory infection. And it was referred to us. The child was very sick. So we delayed, postponed, did one more flexible bronchoscopy. And again, I did not know what the hell was happening. But I knew that it was not 1, 2, 3. And the child, they took the child away to Chennai, I remember, because they got fed up with us. And then they got a bronchoscopy done. And in that, it came out that there was a mid-thoracic tracheal stenosis. And they said they wanted to get the child operated there. Something made them come back to me and tell me about this. I said, look, I've done the, flexible bronchoscopy. There was nothing there for me to think of this kind of a situation. I'm very doubtful, but you're the best judge. You can go wherever. They decided not to go and the child was better. Then we had a workshop and so this child was difficult. I said, okay, let me do the bronchoscopy again. This was 2 days before the workshop to check screen the children. And believe it or not, what I saw there and was actually subglottic hemangioma. Every time the child was on steroids, it would disappear and I wouldn't detect it because the child came and the child was fine. This particular time when I was taking up the child for the case, I saw it, I kicked myself for my incompetence, but then this can happen. Whereas what the virtual bronchoscopy showed was something totally off. I don't know whether it was not properly done or whatever. So always never believe the shadow, like I said. You must have a look at it. So it's got its role, especially in external compression, complex cases, which we discuss now, but that will never, ever be the first investigation. That will never, ever be the primary investigation on which you're going to base your surgery, except in complete tracheal rings, because there could be various areas of narrowing, which, you have to have the length, the width, all that understood to know exactly when you're going to do the slight tracheoplasty as to where to give the incisions, which again, you're going to cross-check by doing a bronchoscopy just before the surgery. So these are all very important not to go by these things.
Thank you, sir.
Welcome.
Next question is from Dr. Deepak Jain, sir. He's asking for foreign body removal, which one is better, rigid or fiber optic endoscopy? Again, we have a session on foreign body. So,
as a rule of the thumb, it's mostly the rigid. But we'll discuss about where foreign body removal with a fiber scope. Please come in and attend the day, that'll be day 3, I believe. Day 3 is at the meeting.
Right, sir. Okay. Next question is from, next question is from Dr. Biplobnath, sir. He's asking, are you using jet ventilations routinely?
No, in our center, we do not have jet ventilation facilities, but Dr. Raman can tell us, we do not have jet ventilation here in our
we don't use jet, sorry.
I think, sir, you have got both jet ventilation as well as ECMO as well. So tell us about both. He hasn't asked about ECMO, but I'm putting that.
Yeah. ECMO, we've actually used only in 2 cases. Both were adults. That's one part. But when you do what is called as an exit procedure, extrauterine intrapartum therapy, it is like an ECMO because the mother is the ECMO machine. She's supplying blood through the placenta. And so we have enough time to restore the airway. We won't go into those details, but ECMO is very useful, especially in laryngeal atresias and congenital high airway obstruction syndrome, where prenatally the diagnosis is made. Having said that, the second part of the question was, sorry, I just, apart from ECMO, what was the other? Oh, jet ventilation. Now, jet ventilation is there. It's not difficult. It can be used. In fact, my first anesthetist, this was when I was in the Air Force, Dr. Shashi Singh Puri, I remember he got a device from the guy who repairs the puncture in the bicycles. He got hold of that, and he had many years back, 15, 20 years back, he designed his own jet ventilation machine, and I remember using it at that time. It is available with us, but I don't use it much. I'll tell you what the reason for that. The problem with jet ventilation is that 2 things. One is anesthesia has improved so much that with an nasopharyngeal trumpet, you can have the same thing. Secondly, with the jet ventilation, the field moves up and down because of the constant thrusting. Plus, there is some amount of fogging also. Thirdly, there is a question of, especially in infected cases like juvenile papillomatosis, I think there's a real danger of getting infected. So when it moves, especially in children, with the field, you're using a telescope, you're trying to see and get the best picture, you're watching the monitor and operating, and the picture is bobbing up and down like the way like this, you can't really assess the depth because we are not at the 3D era. We are still in a 2D is what we get from the present endoscopes. So when this moves up and down, I think there is a loss of precision. So what happens is you might remove a little more or remove a little less, and with this constant movement. That is my complaint against that, but I'm sure people are using it.
And also, so the risk of that ball valve effect of
yes,
proximal obstruction.
Yeah, that's right. That's right.
Thank you, sir. We've come to the end of the questions. There are no more questions. I don't see any new questions coming up.
So if I have your permission and Dr. Gautam's permission, I think we'll accede to the, can I ask Deepa to just put up this evening's program? I know it's very late for whoever's interested. Please join. It's on pediatric tracheostomy. We are having some excellent faculty. Dr. Mary Kurian, who's is the panelist, who's got immense experience in CMC with Bellore. Dr. Sujas Sridharan, qualified from PGI. She's worked at all the best places in the world. She's in Mangalore. She's joining. Dr. Kishore Sandhu from Switzerland will be there. Dr. Deepak Mehta from the Children's Hospital Houston will be there. And most importantly, we always try to project, like we were saying, what work is going on at your place. If we don't project it, who will come to know about it? So we have the technique of pediatric tracheostomy by Dr. Ajay Matthew from CMC Vellore. And post-tracheostomy, my fellow, Dr. Deepa, is talking about post-tracheostomy care. And Dr. Izzy is another airway surgeon doing excellent work in Bombay, which Dr. Gautam Kaund talked about, referred to, where Munier comes and demonstrates surgeries that is on tracheostomy complications. I'm sure this will be of benefit to any airway surgeon, because many of the problems, most of the problems, subglottic stenosis is because of iatrogenic injuries. And if you don't know how to do the proper pediatric tracheostomy, then that's where the problem starts. You give a problem instead of solving it. And lastly, towards the end, there's going to be an open house. Ask questions, please participate. Thank you so much, Gautam, for giving me this opportunity to put up this. This is going to be every Sunday. We're going to move from place to place. It's going to be a lot of experienced people will be there, newcomers will be there, and people in between also will be there. So please, you are invited. Please join us.
We'll definitely join you, sir. And it's been so nice having you around. And I would request Dr. Kesav, Dr. Biswajit.
Sir, sorry to interrupt. There is a last question. Just now it popped up on my screen. This is from Dr. Smritirupa Datta, ma'am. She's asking tips to avoid unwanted serious spasms during dynamic airway endoscopy.
Fine.
It's an open question.
Patho and Parikshit can answer that.
Sanchita, can you please repeat the question?
Tips to avoid unwanted serious spasms during dynamic airway endoscopy.
Okay. Unwanted spasm, it will be, thank you, madam, for the question. Actually, unwanted spasm, it can start from the vocal cord itself, where you can have the laryngospasm, and children with bronchial hyperresponsiveness. Just by touching the bronchus, we might get cases of bronchial constrictions also at times. So how to tips are basically, whenever you're doing a procedure, the most important thing is preparation of the case. You should first clinically examine the style, proper sedation, and especially in a kid, in newborn or in a pediatric patient, conscious sedation is important. Before entering into the vocal cord or into the carina, it's very important that we use the lignocaine spray. And as it is said that you spray as you go. That is a step which we commonly follow so as to avoid spasms. And if you don't know where your scope is, basically just come out and you try to re-enter again, so that you just don't poke and just don't hit the walls of the airway, and this can unnecessarily lead to bleeding also, and at times causes spasms. Biswa, if you can add in.
Yes, sir. Yes, Patada, you are right. And plus, if suppose spasm happens, what to grab things we have to ready. All the medicine we have to ready, or line should be ready. You can't make the preparation if the spasm happen. You have to paralyze the slide. You have to intubate the slide. That things that's very important in case of a laryngospasm. And also putting the blade, as Kesav has showed, basically it is happening in a rigid spasm happens mostly in rigid endoscopy. And generally flexible does not spasm happens because you spray it at the glottic level, wait for a seconds, and observe the again supraglottic area, have an overview of the vocal cord movement, and that time the glottic and subglottic area becomes anesthetized, and you can avoid the spasm. But if spasm happens, be ready for how to handling the spasm. That's most important. The anesthesia is ready, all the medicines related to it.
Thankfully, most of the time, all you need to do is give some oxygen and wait. Most of the time.
Exactly, sir. Exactly. And don't try to manipulate. Open the. I have mostly Kesav have the showing the video. Don't try to open the glottics with your larynx. Don't manipulate too much of larynx. So there's a tendency comes. Oh, yeah, this cell is going to spasm. Let's manipulate it. Just come out. Just come out. Put on a whole and oxygen, and the patient will be relaxed, and he will come out of the spasm.
Just two more questions if you allow.
Yeah, we have got time. We'll try to wind up by in 10 minutes time.
Okay. Dr. Kripamanath sir is asking how bronchial lavage is done.
That's a very good question, actually. I have 5 slides, actually. Can I share the slides, sir, if you allow me? 5 slides, only 5 slides regarding this thing. Where is the presentation? This is the presentation. Then we shall stop. And first day. And
I think we have an excellent audience. Congratulations on getting very interested people. It's not the numbers that matter, it is the quality which matters.
thank you, sir. Thank you, sir. Can I have you seen my slides, sir? My slides are visible, sir?
Yeah.
It's a very, actually, I have intentionally omit this topic in flexible endoscopy part. So, the bulb bronchoalveolar lavage is 2 types. One is a bronchoscopic, one is non-bronchoscopic. Bronchoscopic is a targeted. It's a sample collected from the area of interest. That's why sometimes P of radiology also helps, where you should take the actually more concentrated form of the bronchoalveolar lavage. Generally, we right middle lobe and regular of the lung segment is most frequently sampled because they provide a maximum return. But most important, don't manipulate the scope too much in upper airway. If you have a intention to take bulb, because that will contaminate. If the upper airway may contaminate the bronchoscope, and that may lead to misleading. So, and if you take bulb through an endotracheal tube, so preferably it should sense that endotracheal tube just before the taking bulb. That's the protocol should be protocol, and similarly to the LMA also. So that the scope, where the scope is going, it should not be contaminated. The idea is that. And in case of children, if less than 2 kg, and we should NS of 3 ml per kg body weight in divided dose. Before putting the saline, it's very important to check your suction, and check not only the suction, your suction pressure also, so that it should not be a very high suction pressure. And more than 20 kg, we can go with NS 3 ml up to 20 ml per kg body, up to 20 ml. The suction should be gentle. And the minimum amount of blood fluid always come to at least 30 to 40%. If it comes, it's okay. And 1 to 2 ml of air should be always installed after every, because there's a remaining portion of the saline in the walking channel that we should flush with air, so that everything goes into the bronchiole. And warm saline, not exactly warm saline, it should be the body temperature or at the room temperature. And this NS should be sterile. Don't use the already used NS bottle. And this is very important. Bulb samples should be processed rapidly, less than 40 hours, and keep at 4 degrees centigrade until time for processing and effort to maintain cell viability. And this is the things we look for bulb. All these neutrophil, macrophages, eosinophil, microbiology, and also the cytology. That's microbiology people we should write. The complication is there's a maybe transient hypoxia, and there may be post-procedural fever. So if you're taking a cell with a bulb, we should not send the patient immediately. We should always observe. It's not only for in case of a bulb, in any flexible endoscopy, and we'll always counsel the parents that there may be transient hypoxia in the evening hours if you take. That's all. I think I have covered the bronchoalveolar lavage. Anything, sir? If any remarks are
very nice, very nice. You summarized it beautifully. Fat-laden macrophages sometimes also indicate aspiration.
Exactly, sir. Exactly, sir. And another thing I have found that it is also very important in case of tracheocerebral fistula, in case of cleft, because if the bulb content is high level of pepsin, and that way we can suspect the cell has aspiration. along with the other cytological or infective causes. That's very important.
Anchita, you said there's one more question.
Yes, sir.
Questions are coming now.
There are two questions now, actually. One is from Dr. S.B. Fukon, sir, which I missed. He is asking, there's a case of hemoptysis, no findings in X-ray and CT, etc. How bronchoscopy will help in such a case? This question is put forward to Partho, sir.
Yeah. Thank you, sir, again. See, if you have got a child with normal chest X-ray, as a whole in pediatrics, hemoptysis is not very common. It's a rare phenomena, first of all. Secondly, if you're finding a child with hemoptysis, what are the things that you need to look into, or what are the things that you are thinking of? If it's an infant or a child who is less than 5 years of age, we should always think about an infection. Infection could be because of two things. One is it could be a vegetative foreign body which is lodged, and that has resulted into infection in the bronchus, and that has resulted in a hemoptysis, which may not be visible in your chest X-ray. First thing, and second commonest cause which will present in a early stage is a tracheobronchitis, which can present with hemoptysis in a child. But in both these cases, you will not get a profuse hemoptysis. These are at least scanty hemoptysis. It's usually less than 5 ml. If you're thinking in an adolescent child or in a child who is more than 5 years of age, if you're finding hemoptysis, you should always think about cystic fibrosis and with of course, bronchiectatic changes. Of course, in those cases, we'll have CT or the chest X-ray findings, which will be suggestive of bronchiectatic changes in the X-rays. Of course, I think we should always, with a flexible bronchoscope, if it's a foreign body, we can easily detect it. And if just removing the foreign body will help us to prevent will treat the hemoptysis. Thank you. I think I've.
Yeah, more or less, yeah.
And sometimes you can detect some small hemangioma also.
Yeah. Sometimes if you have got some aberrant bronchial arteries which might rupture, but in those cases we will get a huge large volume hemoptysis.
Yeah.
These are very rare in children.
Cases could be there, like we had this 18-year-old boy with recurrent spitting of blood. There was bleed from the adenoids. Actually, it turns out to be a lymphoma. It was bleeding from the adenoids actually, and it was coming to the mouth and it was spitting out blood. So, Sanchita, there's one more question you said.
One, sir. There's a question by Smriti ma'am. How much amount of spray as you go? As I mentioned in my presentation also, it should be 4 to 5 ml per kg body weight, and it should not be more than 8. It should not be more than 8. That I have found there's a very good by Vijay Sekharan sir on pediatric bronchoscopy. It's a very good book. I have read many times. And if this book has written that it should not be more than 8 milligram per kg. And there's a
thing is that you dilute the lignocaine with normal saline. Just don't put the lignocaine directly. And more of many a times if you take an allergic history, some children are prone to allergic to lignocaine, and you can do a lignocaine allergy test. Just by putting a few drops, 1 or 2 drops of lignocaine in the oral mucosa, you can look into the allergic. If the child develops hypersensitivity, in those children you can avoid lignocaine. This is one thing you should look for before putting lignocaine into the carina or into the vocal cords.
There are lots of comments. I'm not going to read the comments. Comments from Orpit, Biplab, they're saying excellent presentation. But there's one question by Orpit, sir.
Okay.
If you are suspecting tracheocerebellar fistula, not able to see it, whose investigation will you rely on?
Who answers?
I love to answer. If you pardon, you want to answer, please.
I know that you want to answer that.
It's okay. It's very excited. Why are you suspecting a tracheocerebral fistula? First of all, this is only a case when you have persistent pneumonia, or you have a case child with a recurrent pneumonia, or a recurrent cough which is not responding to your treatment. These are children where you will think about a H-type tracheocerebral fistula, because other fistulas they will usually present at birth, which will be easily diagnosed. H-type of fistula which can present later on only. So if you are suspecting H-type of fistula and you're not being able to find a diagnosis, I think the flexible bronchoscope will definitely help us. And Vishwa has already shown the picture also, where we can see the fistulas opening just behind the carina. and that is the best part, best way to investigate a child in a child with prolonged cough or a recurrent pneumonia or a child with persistent pneumonia.
Pete, it's for you, this visual, because we don't know how we got the idea. What we did, we have seen the fistula, because that's a once operated case for the tracheocerebral fistula. Then, but the physician has an issue, they have aspiration again. The both lung has an aspiration. Then we have seen there's obvious fistula, but how will you confirm it's a fistula? Then what we did, there's already rise tube in the esophagus, neoesophagus. We just withdraw the rise tube up to picopharyngeal level. Then we inject some methylene blue. Then we can appreciate that methylene blue is coming out through the fistula step. So that's confirm that there is a tracheocerebral fistula. And second, if the fistula is bigger in size, then you can negotiate the scope also through the fistula and enter into the esophagus. So this video will show in the later part, this methylene blue is coming out. Just a minute. Can you appreciate this blue dye is coming out to the trachea? This blue dye is coming out to the trachea. So that's how we can confirm that this is a tracheocerebral fistula. Thank you.
Yeah, that's a good way of confirming, but because thanks to the telescopes, I mean, most of them, I mean, there may be a few which you can't detect. You can find a puckering in that place, and the dye test is absolutely fine.
He's calling it the Gogo's dye test. I think we have come to the end of our questions. There's no need to read the comments. We will keep that for our records. Sir, before we end, before with your parting remarks, I would like to request Dr. Kesav to put on his camera. Parikshit must have left. I would like to call Anjana to stand behind. Thank you, Kesav. To stand behind Dr. Partho and Dr. Sanchita also. Daisy has gone for another webinar. So this is the first day. Sir, your parting remarks by the time they come along.
Sorry, sir.
Yeah.
Sorry, sir.
Yeah.
Again, the Arpit has a question for Aman, sir. Any radiological investigation for tracheocerebral fistula? This is last question. Mostly is the last question.
I think very guarded, maybe would a thin barium or something. I don't know. I'm not sure. I think what you're doing is much more sensible. I'll have control over the patient, total control. Riles tube is there, or feeding tube is there. Just put a little dye and see it. That would be, I think so. Not the most experienced person in tracheocerebral fistulas, mostly handled by pediatric surgeons. So I don't have too much of clinical experience, I must confess.
Thank you, sir. Thank you, sir.
Sir, this is almost our entire team, except Daisy, who has gone for another webinar she's got from the Anesthesia Forum.
Thank you, sir.
Thank you, sir.
Thank you. Really appreciate calling me. And congratulations, Gautam and your team. Fantastic work. Just keep doing what you're doing and enjoy yourself.
Thank you very much. Looking forward.
Thank you, sir.
And I learned a lot today during the session. No, honest to God, honest to God. That's why I said, let me trespass into your other sessions also. Thanks to COVID and the way the questions were asked, questions were multiplying faster than the coronavirus.
Thank you, sir. Thank you.
Okay, sir. Thank you.
Thank you.